Will you bow your heads with me, please? Almighty God, thank you for all of your blessings. We are grateful for another opportunity to do work on behalf of Mississippians. We thank you for being a God of justice, and we ask for your strength to do and to be all that you desire for us, to be servants and not oppressors, to share rather than to hoard, to empower rather than to demean. And now let the words of our mouths and the meditations of our hearts be acceptable in thy sight, O Lord, our strength and redeemer. Amen.
You'll turn your attention to the flag for the pledge. I pledge allegiance to the flag of the United States and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. I think just a second.
I'd like to take this opportunity to welcome our court reporter, Julie Brown, who will be here today and maybe tomorrow. And I would also like to welcome Liza Hayes, Assistant Attorney General, who is going to be our hearing officer today. And do we have a roll call?
That's, sorry. We're working on a link for Dr. Owens. So we'll start. Dr. Lippincott.
Here.
Dr. Joyner.
Here.
Dr. Kennard.
Here.
Dr. Gersh.
Here.
Dr. Givens. Dr. Dotson.
Here.
Dr. Loper. Here. Mr. Breland. Ms. Gaines. You have a quorum.
Thank you, Dr. Phelan. Do we have any other announcements or public comments? If not, we'll proceed to the executive director's report.
All right. So for this, we although usually I report on what happens in July and August, not what actually happened in September. But this was such a special occasion, and we had the proclamation for Major General Herron at the last board meeting, that I wanted y'all to know that Mrs. Gaines and myself went and visited him and presented him with his proclamation. And he sent a hearty hello to everybody and said to keep up the good work. So getting into the actual report itself, and licensure, there was 154 new licenses issued, as opposed to 167 in the last period. No new podiatrists, 18 new PA licenses, no new acupuncturist. Through the compact, we actually issued an additional 178 MD or DO licenses, previous being 220. The number of licenses that we issued through the compact continues to be more than the traditional method of issuing licenses on a regular basis now. We certified to other states 459 licenses. In investigations, we received 94 complaints. We were able to close 24 cases. We only opened 12 new cases. Total cases open at this time is 62. And then we were able to improve our number of closed within 7 days from 43% to 60%. We requested 53 prescription monitoring program reports. 16 of those required additional investigation. Today, as we have been meeting with the Legislative Budget Office, I was going to remind the board where we stand in the budgeting process and what our budget requests are, and at the end, ask for the board's approval of this request. In salaries, we're requesting 2.6 million and some change.
That's our current budget, so
I'm sorry.
that's our basis to start.
I'm sorry. All right, so this is the current budget. I need to read my own titles, right? This is what we're operating from in this fiscal year. Salaries, 2.6 million, a little over that. 50,000 travel, contractual services, 815,000. Commodities, 50,000. Equipment, 122,000. Subsidies, loans, and grants, 730,000, giving us a total budget authority of 4.4 million and some change. For the fiscal year 2026 request, we're requesting essentially the same amount of funding at for we're bringing forward the 2025 fiscal year. New positions we're adding will require an additional $229,000, and then progression, as it's known in the state, or raises, as it's known everywhere else, was 55,000 this year, giving us a total request of 2.9 million and some change. We will be requesting a second attorney this fiscal year. That will fringe and everything will cost us 126,000. We're also requesting a public relations specialist. Once again, with fringe, 103,000, bringing that total to $229,603. In-state travel, 20,000, out-of-state travel, 23,000, board member travel, 7,000, giving us a total of 50,000 for travel. Contractual services, which includes building rent, copier rent, legal services, maintenance of the licensing system, and payments to other services or other agencies, ITS and DFA, and then our legislative service. That comes to 815,000. Commodities, as you can see there, the stuff that makes an office work, the copy and paper, the notebooks, the promotional items, fuel, and food for business meetings, $50,174. Equipment, y'all may remember we started a program of exchanging out 25% of our electronic equipment every fiscal year. That will be 113,750. Also includes other things such as furniture and vehicles. Our grants for this year will once again be the Physician Health Program at $600,000 and Mississippi Board of Pharmacy for the PMP program, $130,000, giving us a total of $730,000. So when you add all that together, you get a total budget request of $4,711,129. And so prior to this meeting, you were all issued a full budget for your review. So if you so pleasure, and so at this time, I hope y'all had a chance to look over that. And between that and my presentation, I'm more than happy to answer any questions. But then I would ask for board approval of this request at this time.
Thank you, Dr. Cleveland. Any, questions or discussion? Uh, do we have a motion to approve the session?
Hey, this is Tom Joyner. I move we approve the budget as written.
Yeah, I'll second. So, all in favor? We have a motion and a second. Would all in favor, say aye?
Aye.
Opposed? Any abstentions? The motion is passed.
Thank you. And then, any other question? Any other questions about any parts of the presentation was other than budget, since we've already covered it? All right, thank you.
Thank you, Dr. Cleveland. The next item is approval of the minutes of the executive committee for July the 17th. The minutes have been published for your review, and we have a motion for approval of the minutes of July 17th executive committee.
So moved.
We have a motion and a second. All in favor, say aye. Aye.
Aye.
Any opposed? Any abstentions? The motion to approve the minutes of the executive committee passed. The next item is the approval of minutes of the board meeting for July 17th. These have been published for your review. Any discussion for the minutes of the last board meeting?
So moved.
We have a motion and a second. We have a motion and a second. All in favor, say aye.
Aye.
Any opposed? The motion is passed. Next item is a report of the August 22nd specially called executive committee meeting. These minutes have been published for your review. Is there any discussion? If not, do we have a motion?
So moved.
We have a motion for approval. Have a second? Second. All in favor, say aye.
Aye.
Aye. Any opposed? The motion to approve the minutes have passed. The next item is a report of the September 25th executive committee meeting. The executive committee met this morning, and I served as secretary with Dr. Joyner, and we had a request for an exception to the 20/80 practice rule by Dr. Robert Dale of Tupelo, and we granted the exception. And we had a request for an exception to the 75-mile rule by a dermatologist in New Orleans who had a PA working in Biloxi, and we approved that exception. Do we have a motion to approve the report of today's executive committee meeting?
Second.
All in favor, say aye. Any opposed? Motion is passed.
Dr. Lippincott. Got that out of the way. I believe we need to approve that August 22, sorry, the August 22 specially called executive session. I have that on this sheet. It'd be agenda item number 9 as it's labeled here, just ahead of today's meeting. Is there's one more previous meeting from August 22nd. Do you have that? You need to approve those minutes as well.
Let's see. We approved
Yeah, and so when you were going through them, you combined number 8 and number 9, the report of the executive committee meeting
All right.
and the approval of the minutes.
So we can combine those.
Yeah.
All right, fair enough. Got it.
Did we get a report? Do we need a report on that?
Well, I don't, y'all have the information in your binders.
Yes, it was published.
So,
Report is on your tab.
All right, we'll consider it combined.
Thanks, Dr. Kennard.
Yeah, that's it.
Okay, and the next item is a report from the Physician Assistant Advisory Help. The Physician Assistant Advisory Task Force.
Yes, that's me. First meeting in a while, this committee, and it was more of general update from physician assistant organization head by Mr. Ibarra. But it was functional and practical, and we made some general recommendations for their concerns. So the update part was introducing new members and their status in their organization. And then probably the biggest concern that was raised was over the recent legislation that prohibited nurse practitioners or PAs from manning an emergency medicine and emergency department autonomously without physician oversight. And that is something that is a fact, but we recommended they reach out to MSMA, for further in-state CME development and support for their desire to do so. Ken, do you have anything to add to that specific item? And then I'll catch the other ones real quick.
No, there was some discussion about use of laser devices.
Yeah.
Without immediate supervision of a collaborating physician. But
Yeah.
that was just general discussion.
That was another clinical point. And then they made a request, which is reasonable, about including themselves in part of our compact licensure program, which is something that we can actually probably help them with. And then a general update on the PA programs in the state. So if anybody has questions about any of that, I'm glad to field them, but that was essentially it.
Thank you, Dr. Kennard.
Yeah.
Is that it?
That's it.
Okay, thank you.
So we can,
Okay. Item 12 on the agenda is a semaglutide waiver request. We have Dr. Jennifer Bryan addressing that.
Good morning. Can everybody hear me okay?
yes.
Thank you for having me. My reason for being here on behalf of State Medical is to discuss the strong work you guys have been doing on semaglutide and like compounds, and also the compounding issue. Worked with Dr. Cleveland and Paul Barnes on some verbiage, and I think you guys have that before you in your packet. Do they have that? Okay, if you don't mind. Just to maybe add just a little bit to it, by way of background, I don't have to remind you guys about what all issues you dealt with successfully with the compounding Ozempic that came across the state and how you pulled that back into order.
Thanks.
We heard issues from doctors across the state, myself included. I practice family medicine here in Flowood with Patty Ford Clinic, where a little bit of the baby got thrown out with the bathwater and it was not intended. And every board member that I talked to would say, yes, you can prescribe Ozempic for obesity. But the way we interpreted the verbiage was that there was wiggle room there. So the way it has been written is you can only write FDA approved GLP-1 or GLP-1 GIP agonist drug classes that are FDA approved. But there's only 2 of them. And they're about $800 each for a month supply. But our refrigerators and sample cabinets are full of the ones that are not FDA approved, many times the exact same chemical compound. We know the studies show that it's effective for obesity. We feel like it's much safer than many of the other options that are out there right now being prescribed. And we know that we are a very obese state and have an obesity problem. And so we're asking for the off-label ability to prescribe medications to help our patients. You've already approved those that are FDA approved. We just want to be able to write off-label. It's a pretty straightforward request. I think in working with the board members, we all want to be able to help our patients and not get in the way of that. And so it simply adds to what you already have before you that you guys have done. It says further non-compounded commercially available GLP-1 agonists and GLP-1/GIP agonist drug classes may be prescribed off-label for patients who demonstrate clinical need, which includes the treatment of obesity. And I'll just end with an example, and I'm happy to answer questions. But if I had a patient in my clinic that wanted to be treated for obesity, and I prescribed, as it is right now, Wegovy, which is the exact same chemical compound as semaglutide, Ozempic, I could not legally give them a sample of Ozempic to leave because that's a different drug. I'm not allowed to do that. So we're just asking for our hands to be freed in that situation. So happy to answer any questions. And thank you guys for helping us work on the verbiage.
So, thanks, Dr. Bryan. Any questions for Dr. Bryan?
My concern is that it's being done. People are doing it across the state already, and it's just unnecessary risk, really. I mean, family doctors and internal medicine doctors across the state are doing this, helping their patients. So it's just cleaning up the regulations.
So I guess my question is this just requesting an exception for Ozempic, or is this or
That class,
a
right.
class of drugs that is not specifically FDA approved for obesity, but
Right, but they all help obesity
but these are all FDA approved drugs for
for
other.
diabetes, right? But the science shows that they do help obesity. So not unlike what we prescribe off-label every day in our practices, medications that we don't require FDA approval to prescribe if we know it will help the patient. You guys know.
But this request, it does not address the question of compounding.
This is in addition to what you've already done. Like, you've done great work with compounding, has nothing to do with compounding.
The compounding was already approved.
Okay,
Yeah, it's,
This is just the request previously only included compounded drugs and it left out commercially available drugs. So this just completes the whole thing and makes both compounded and commercially available okay to use for the treatment of weight loss.
because as you know, these drugs have been FDA approved, gone through rigorous safety studies. So I would put forth they're safer than many other things that are already okay to prescribe. So just again, closing that loop.
okay, thank you.
Okay, thank you guys.
Is there any other questions or discussion? Do we have a motion regarding the semaglutide waiver request?
I'll make that motion
What's the motion?
to approve their request
Second,
as stated in their language that's underlined in our material.
Okay, we have a motion from Dr. Kennard and a second from Dr. Joyner. Do we have all in favor, say aye? Any opposed? Do we have any abstentions? The motion has passed and thank you. Anything else on item number 12, semaglutide waiver request? Thank you, Dr. Bryan. The next item on our agenda is addressing the question of CRNA collaboration.
Yes, Dr. Lippincott, this is an issue that's been brought to the board staff and the executive director several times in the last year. You may recall that in the spring, it was requested that the board issue a declaratory opinion related to the appropriateness of CRNAs being, permitted, for physicians to collaborate remotely, anesthesiologists to collaborate remotely with CRNAs. Ultimately, the board determined that it was, the request did not meet the requirements of the rule and did not issue a declaratory opinion. But as we need this issue has continued to be brought to the board by various practice groups. This was initially placed on the agenda because we had a licensee who was requesting that the board approve an exception permitting anesthesiologists at a remote location to collaborate with CRNAs at a remote surgery center. Yesterday, they informed us that they did not wish to present their exemption request yet. They want to wait, I believe, till at least November to have all their ducks in a row. However, there are a number of anesthesiologists who are here today who wanted to speak about the proposed exception or exemption request. And because we believe that this issue is going to continue to come before the board, and because these anesthesiologists are here today and have requested to speak to the board, we think it would be appropriate to allow them to go ahead and express their views on this subject, which will come back up before the board in the future.
Okay, thank you, Ms. Barnes. So, we have, Dr. Ann Ray who's ready to address this issue.
Good morning. I'm glad this is clear because you can actually see me behind it. For those of you who don't know me, I'm Dr. Ann Ray, MD. Specifically, I live in Columbus, Mississippi, and I'm here to address this issue. Hopefully give you some clarity. Can you hear me? If you will. I have some supporting information for all of you. And like I said, I'm here from the Mississippi Society of Anesthesiologists, specifically representing that body. This has been an issue which is clouded, and I'm hoping to bring some clarity to you on the practice of anesthesia. First of all, how anesthesia is different from office practice and how it's unique unto itself. How these definitions have come about in terms of direction, clarification, thank you. And what is actually in your regulations as on the website and what's on the nursing regulations on the website, and how these mileage rates really do not apply to the practice of anesthesia with anesthesiologists and CRNAs. I've given you some information, well, which is back up to what I'm going to tell you. I'm sorry, Dr. Joyner, I don't have any slides to present to you. I see you waving up there. And
Just scan and send it.
you can. I'd be delighted for you to do that. Thank you. First of all, let's talk about the nature of anesthesia practice. Anesthesiology is not an office practice. It's hands-on, minute to minute, not hour to hour, not day to day. What we do occurs very quickly. Seconds make a difference, minutes make a difference in the outcome of the patient sometimes as we come into problems. Anesthesiologists and nurse anesthetists work together on a team. That has been documented in different studies as that's the best practice model. That model is defined by the American Society of Anesthesiologists, and that definition is also put together with CMS. And within these two bodies, you don't see the word collaboration. It's medical direction, supervision, which is basically how many CRNAs you cover at a time. But no matter how you define it, direction or supervision is defined by ASA and by CMS as immediately available. That doesn't mean I'm in the hospital and you're in the freestanding clinic. I'm doing a pain practice in an office and you're in the hospital. immediately available. Because what happens in anesthesia happens now. And you'll see some of that here. I gave you a sheet on statement physician-led anesthesia care from the ASA. I don't have the documentation from the CMS, but it is a reflection of that. Part of what we do too is also been recognized as different by the state of Mississippi. You have in your packet a letter from Governor Phil Bryant, where the question of opting out of CMS, Medicare coverage with CRNAs was brought up, and that was rejected because of the nature of the relationship with CRNAs. And you'll note that in this letter too, that it's very close collaboration, supervision, and that the practice is of such a dangerous nature that we want to keep this together in this immediate relationship. In some small places where there's not an anesthesiologist, the CRNA is being supervised by that surgeon who is doing the procedure, whether they like it or not. They're the supervisor. And that anesthetic is not given without the presence of that surgeon. So there you have that close physician CRNA relationship that you don't have in an office practice. You'll also note here, there's a letter from Mr. Hood, who is the Attorney General, talking about clarification of nurse practice, and he's reminding us there that CRNAs and nurse midwives are not the same as a nurse practitioner by the State Board of Nursing and do not have prescriptive authority. So they work within that framework. They are not the same. Okay. We're going to go now to the State Board of Nursing. And when you look at their stuff, I think I have that in here too. You have three kinds of advanced practice nurse, registered nurses. You have the nurse practitioner, who is the office-based person who has prescriptive authority. You have a nurse, certified registered nurse anesthetist, who does not have prescriptive authority. You have a nurse midwife, who does not have prescriptive authority. So you got three brands of advanced practice nurse, registered nurses. Okay. And this is, I'm giving you definitions for clarification. When you go to your own regulations, and I'm going to take you to your own page, and this came off the web page. This is not part of my imagination. Okay. When you look at this board's regulations, you see that nurse practitioner and APRN are the same in the definition that's here in this board. I'm going to tell you that's erroneous. But it was made because at the time, this board was only dealing with nurse practitioners who were going to work in an office practice. And if nurse practitioner under this board is the same as APRN, or APRN has been limited to nurse practice by this board in your own definitions, then that's where the mileage applies. And all the language in there is only about that relationship, that office practice, and that mileage. That when you talk about it, does not include CRNA or nurse midwife. Therefore, for these, none of that mileage applies. Are you with me so far? Okay. Now, I'm going to reiterate, you cannot supervise, direct, collaborate with a nurse practitioner under CMS regulations, ASA standards, anybody else's standards, hospital regulations from a distance. Everybody I've ever been to has immediately available. And I'm going to reiterate, these mileage criteria do not apply to CRNAs or nurse midwives by your own definitions. Because you narrowed the definition of APRN to nurse practice. And if anybody wants to direct them from a distance, they're in violation of all these different traditions, practices, regulations, recommendations. Any questions? I'm here for clarification. I'm not afraid to answer questions. Y'all know me.
Thank you, Dr. Ray. Uh, So, regarding this question of CRNA collaboration, so you are opposed to exceptions to the presence of anesthesiologists with the CRNAs. Is that correct?
I don't understand.
The current regulations require the presence of an anesthesiologist with a CRNA, or you said that it's permissible for a surgeon to supervise the CRNA.
It's a physician-nurse relationship that's special, and if an anesthesiologist is not, say, you're in some small town that doesn't have an anesthesiologist, but you do hernia repairs, okay? There's a CRNA there giving anesthesia. Or you're in the plastic surgery office, there's not an anesthesiologist, the CRNA is giving anesthesia. That CRNA, by definitions of CMS, is being directed by that surgeon.
Right. And that's not uncommon, is that correct?
It's in different places, yeah.
Okay.
That's not uncommon.
And I was just interested, you made the statement that CRNAs and nurse midwives do not have prescriptive authority. What exactly does that mean?
It means they can't write a prescription for an antibiotic. They can't do anything outside of the place where they're actually practicing. What they give and administer in terms of medications is covered within the hospital scope and within the hospital DEA. That they tend to draw it up and give it themselves.
But you said that the position of the American Society of Anesthesiologists and CMS and the Mississippi rules and regs all are consistent in that we require the presence of a physician with the CRNA. Is that correct?
Right.
And I didn't quite understand your point about APRNs being not synonymous with nurse practitioners. Does APRN, does that include
According to the
CRNA?
nursing board, there's 3 kinds of APRNs. I don't see Ms. Johnson. I see some nursing board people.
We have,
You have nurse practitioners, CRNAs, nurse midwives. And they are not the same. Each one is a different entity under the broad heading of advanced practice nursing. It's a general term for 3 kinds of practitioners.
okay,
Nurse practice is not CRNA, is not nurse midwives.
okay.
The way this is defined in this board, though, nurse practice and APRN are the same, which is not what their board says.
Okay,
But everything in that was, when these things were written, and I remember, everybody's thinking about nurse practice in the office. And these things were not intended and not defined, keeping in mind nurse midwives and nurse anesthetists. because they're not the same.
Well, thank you, Dr. Wright. Any other questions?
I don't-
Good morning, Dr. Ray.
Good morning.
I'm Renee Dotson from Greenville, Mississippi. Thank you so much for your presentation. I just want a point of clarification. In some of those surgery centers and in smaller towns, when the surgeon is the physician of record, is it your premise that that is an inappropriate arrangement for the CRNA as well?
It's just the way it is.
But
There
I mean,
aren't enough anesthesiologists go around to every little place, but that nurse anesthetist by CMS and by the state of Mississippi is collaborating with that surgeon.
I understand that. So,
They
but
don't
my,
always understand it, but that's true. And I think, I don't see anybody here from that. There you are. I don't know if you can clarify that for me. They can't clarify it for me.
so I'm seeking clarification here because the insinuation is that that is an inappropriate, by your standards, that is an inappropriate relationship or collaboration.
It's just the way it is. And what the real question here is, can I, as an anesthesiologist, collaborate with nurse anesthetists in different remote locations? No. To clarify, what we're really here to see about is if I'm collaborating with a nurse practitioner, I'm immediately available
Okay. Thank you.
by
But-
regulatory, by CMS, by everybody else. Immediately available is that relationship between me and a certified registered nurse anesthetist. And I cannot look at myself in the mirror and collaborate from the seventh hole at Annandale with somebody in the hospital under anesthesia. Or at the plastic surgery office down the road. Or I've got somebody here at the plastic surgery office, and I got somebody over here at the hospital, somebody at the office-based practice. I'm not doing my due diligence if I'm not immediately available. And that's what all of my standards say.
I mean, I have no argument with what your standards are saying. As a surgeon who has had to collaborate with CRNAs because I had no other anesthesia
Right.
available, I understood that I was the physician of record and the collaborator. in
And
that
you are
situation.
immediately available because they're not going to give an
Because you're-
anesthetic without you there.
Because you're right there, but so the whole premise of my question was, because the way the presentation was given was that in itself even was an inappropriate relationship.
I can't address that. And since that's gone on for years and that's recognized as regular, I'm not going to address that. And I'm not going to tell you it's inappropriate. Now, if you have people going to sleep and you're not there and they're still asleep and you leave the operating room, go back to your office and your patient's still asleep, I might have some questions about that.
Oh, well, there are a lot of semantics and a lot of scenarios that we could go down. I could
We
take
go
you
down a
really
lot of
far
rabbit
down into a
holes.
rabbit hole with that.
Yeah.
That I think I'm just trying to get a broad sense of it, that there are different kinds of collaborative relationships.
Okay.
But that the linchpin of the relationship is that the person who is doing the overseeing is immediately available.
Right.
So we agree on that language
Mhm.
and in that situation, but to parse it out into every possible scenario won't be good for either, for
We're not here
anybody.
for rabbit
anybody.
holes, 'cause
Yeah,
this is
so-
regulatory body.
Yeah, so, that, you answered my question. Thank you.
Thank you. Do we have any other questions for Dr. Ray?
There are two other speakers here. Do you have anything to add that I haven't covered?
No, just to basically reiterate some of the stuff you said, but nothing extra.
Can I ask a question?
Sure.
Is that okay? Yeah, so I think you've done a good job of explaining, so good that you cause confusion. Sometimes you can do that. So I think Dr. Dodson and I are on the same page wavelength. Let me make sure. You're not denying that the current standard is either an anesthesiologist be actively present or a surgeon be actively present. Either of those physicians has to agree to the terms of that and know what they're getting into.
Right.
Okay. Your main issue is with a distance collaboration just with an anesthesiologist with a surgeon that has not agreed to be the collaborator.
I can't be the collaborator from a distance.
Okay, so that's what I wanted to know. But you're also not denying that that's kind of where we are. If the surgeon agrees, you can have an anesthesiologist on 7th hole at Annandale helping with pre-ops
No,
and questions and concerns about an
No.
upcoming surgery.
I'm immediately available. I'm actually involved in that care. That's what all the ASA standards say, the CMS standards say. I am preparing that patient. I'm involved in that preparation. I'm involved in that anesthetic choice,
Right.
and I'm immediately available for problems.
On
And
site.
that's the standards,
Okay.
as written by the American Society of Anesthesiologists and duplicated in CMS regulations for supervision direction.
Okay, got it. On site, all of that needs to be on
Yeah.
site. That's all I want to
If you don't
clarify.
want to be on site, you're on your own,
Right,
Mr. Surgeon.
right, exactly. But if Mr. Surgeon,
Dr. Surgeon, you're on your own.
if Dr. Surgeon says I'm okay with it, the
Well,
case
that's
goes
his
on. Right, but
So
the
I'm
case
not
goes on.
collaborating.
Okay, no, I understand. And you shouldn't be on the hook for that at that point. All right, got it.
And if I'm not immediately available, I call myself collaborating, directing, supervising. I'm not doing my job.
Gotcha.
Y'all agree with that?
Yep, that's good.
My, Dr. Stout, Dr. Robertson,
Thank you, Dr. Ray.
also members of the Mississippi Society of Anesthesiologists here.
Yes, we have 3 more people on our speaker list here. Dr. Wegener, he's not here. Okay, Dr. Stout.
Thank you. Thank you for allowing me to
Robertson,
speak.
thank you, Dr. Ray.
Y'all hear me okay?
Yeah.
Yeah, I don't have a whole lot to add other than the fact that to me, it's hard to understand how you can equate collaboration when it comes to a nurse practitioner and equilibrate that to a CRNA. Both of them are critically important to our healthcare system. We need them. There's no question. But if I'm a nurse practitioner in New Albany, okay, and I've got a question about a patient, about a medication, I can pick up the phone and call my collaborating physician and go, hey, I'm not real sure. Can you help me out here? And they can come up with a solution. They can take as much time as they need. Doesn't matter. And come up with the right solution. If you're a collaborating anesthesiologist and you've agreed to put a patient to sleep with a CRNA that's in New Albany from here, and they call you 2 minutes into the procedure and say, we can't get an airway. This patient's crashing. What can you do to help? There's nothing you can do. There's zero. And not only is that a problem, the patient's going to potentially die. And so I feel like this board is, our job is to keep the patients in Mississippi safe and do the things that make patients safe. And a collaborating anesthesiologist does not do that. It does not accomplish that. We need to be on site. We need to be present in order to help. And it's the same with surgeons. The majority of places in Mississippi have physicians. They have anesthesiologists. There are some that do not. But those surgeons sign the charts and have expertise in emergency airway management. And so if you get into that situation, that's what they've signed up to do. And I think that's critically important, that this is not the same as nurse practitioner. It is a completely separate field of medicine. Not to downgrade or talk bad about them, because again, CRNAs are very, very good at what they do. They're very important, but we are too. And it's important for us to be involved in the care, or a physician be involved in the care. Anybody have any questions about that? Thank y'all for listening.
Thank you, Dr. Stout.
Hess Robertson, I'm an anesthesiologist in the ICU position. I have a little bit of a unique perspective. I work with CRNAs and nurse practitioners. I work with nurse practitioners daily in the ICU setting. I work with CRNAs daily in the operating room setting. Usually not at the same time. That's kind of frowned upon, but the weeks I'm in the ICU, I work in the ICU. The weeks I'm in the OR, I work in the OR. We collaborate with CRNAs and we collaborate with nurse practitioners. It's a little bit different. When I'm working with CRNA, I'm on site. And I work at a tertiary care facility. And will always probably be at that kind of place. And for the kinds of things that we do in the acuity of our patients, having somebody like me involved in the OR is important to our patients for their safety. It's a little bit different once you get to the ICU. Seconds and minutes matter more in the OR. And I'm saying that about myself, my own profession. There's a difference that things can change a lot quicker in the operating room than they can in the ICU. So I just want to kind of give you my perspective on that. I don't think any of us would support a collaborative relationship from a distance. I think that would put patient safety in jeopardy. I think if you're going to be collaborating, you need to be immediately available. You need to do what you can for that patient. And to do that, you need to be on site. Thank you. Any questions about anything?
Thank you,
Yes, sir. Yes, sir.
Do you think most surgeons are adequately trained in airway control?
I think if they are the supervising physician, they're directing, prescribing, I need anesthesia. I think they ought to have some training in probably establishing surgical airways. That's what I personally think. I wouldn't personally have a surgery and operation in a place where I had doubts about that. I
They
think
don't have to have documentation. They're not.
Well, that's up to the facility that they're at and credentialing them and doing all that kind of stuff and giving privilege. I mean, that's a facilities question at that point. It depends on the facility. It depends on what they want their surgeons to have. I do some of that, and I know that runs the gamut too for credentialing stuff. So the privilege. That's a facility by facility question.
Thank you, Dr. Robertson.
All right,
Thank
you.
Dr. Lippincott. Ms. Julie Mitchell, who's an attorney who represents an ambulatory surgical facility, is asked to speak.
Okay.
Sure.
Yes, please.
Julie Mitchell, and I think this is a good topic, and I'm glad I could be here. I didn't prepare to be here, but I'm here anyway. Once I heard this was going on, I actually got in my car and drove down here. So I think that what we all heard is that in Mississippi, what our regs are requiring of our rural hospitals, our AMSURG centers, which we are in desperate need of these services. But what we've heard is that what we require in Mississippi is to have an anesthesiologist directly on site, immediately available to the CRNAs. The question to the board is can we afford that in Mississippi? There are 27 states that have opted out of that model. It is not the leading national model. The leading national model from the Anesthesia Association is that they use the collaborative approach because that's what they can do. That can provide the services to these rural areas that do not have an anesthesiologist sitting there directly available in the office suite. I've currently got a client that has an anesthesiologist who sits in the office just so he can be directly available, but they can't afford to keep that model up. They use CRNAs like most of our rural hospitals and most of our rural providers. That is an option. Our state can opt out. CMS regulations do require that you have an anesthesiologist or other physician on site. That's not what we require in Mississippi. We directly require anesthesiologist and no other be on site. I think that was what the underlying tone was earlier. CMS goes further to say, unless your state has opted out of that model. Unless your state has opted out of that model. 27 other states that I know of, maybe more, have opted out of that model due to the limited access to anesthesiologists being directly on site. There are options that the state can consider that you can look at, like whether or not you want to allow the surgeons to be on site and then have a collaborating anesthesiologist off-site. Or you can do the standard national practice, which is the collaborative model called the CAT model, where your anesthesiologist collaborates with the CRNAs that are not directly available. What we do need in Mississippi is some guidelines to follow. We need clarifications. The board is complaint driven, meaning only if somebody tells on a anesthesiology or an AM-Surg group, will they go look at it and demand that they now get the anesthesiologist and pay for somebody to sit on site. But we know they're all not following that model. Our hospitals, our rural hospitals, I'm from the Delta. A lot of AM-Surgs, they don't have guidance and they don't know what the rules are. And a lot of them, as you heard, historically have not followed the model that our state has in place. So not surprisingly, we asked for a declaratory opinion back in February. And we would like, and I appreciate the opportunity to be here. And I think this is a very timely topic, and I hope the board will give it some consideration and provide an opinion and answer these questions so that we can all get on the same page and then get together and talk about what's the best program for Mississippi, given our rural status. So that's all I have.
Thanks, Ms. Mitchell.
Thank you.
Any questions or discussion from Ms. Mitchell? Yeah, Dr. Wright.
I've been doing this over 40 years in private practice, and I've seen a lot of change in this state and whatever. We don't have any laws about having anesthesiology for places. We have made great strides in making a better system by providing anesthesiologists for this place. Now, what she's proposing, I'm going to tell you, there are people who have come here from out of state, from Louisiana, sitting in a hospital in Baton Rouge, wanting to collaborate with nurse anesthetists on the coast and in other places. That's a business model. And that is a business model directed at making money without the responsibility. And they're telling these companies that these people can have their cake and eat it too. That the surgeons don't have a responsibility, even though I'm sitting in Baton Rouge and you're on the coast of Mississippi. That's a business model. Now, that's what's being driven here. It's a business model, not a practice model. And when I sat on this board, and I know all of y'all were in agreement then, that we were about what was best for the citizens of the state of Mississippi, according to our laws, our regulations, and what we have expected for our people to expect from the practice of medicine here. And this board has always told other people coming in here with other models, you build your business model around our regulations. We don't build our regulations around your business model. Now, all I'm going to do here is come here and tell you what's the best practice. I can't tell you that everybody can have an anesthesiologist. Not everybody can, because there's only so many of us. We're trying to produce more, like we're trying to produce more surgeons and more family practitioners and everybody else. We do the best we can. We can't answer all the questions today about everybody's needs and what they perceive their needs to be. But at the end of the day, what's best for our patients? And that's the standards that we've already set forth as what's the appropriate care. Thank you.
Thanks, Dr. Wright. Do we have any other questions or discussion for Ms. Julie Mitchell? Anything?
And I wasn't suggesting any, I was just pointing out that we need some clarification. If our standard in the state is to require an anesthesiologist to be on site at every facility, then we need to let people know that that's what we require. If we are okay with allowing a surgeon to be on site, then we need to let people know. But what I understand, and maybe I'm wrong, but what I heard is that we need to have an anesthesiologist on site, and that is what we're proposing is the best practice. But we need to let people know that that's what our standard is, so that people can adhere to what the requirement is. Understood, those were some of the questions asked. Is that what we're requiring? Anesthesiologists must be on site, directly available. And that is what we are saying is the best practice, but we need to tell people that that's what our practice is, if that's what it is. And require it of everybody, not just one or two or three, everybody.
Thank you. We'd like to recognize Dr. Brunson.
Thank you, Dr. Lippincott and members of the board. I'm Claude Brunson. I'm a former chair of the Department of Anesthesiology at UMMC for 10 years. I've been training anesthesiologists and CRNAs for my entire career. I also had the privilege of being on the board of directors for the American Society of Anesthesiologists for 17 years, where we actually looked at and made policy for safety in anesthesia across the country. The reason the issue came up about immediately available is a safety issue. Anesthesia is a medical specialty. It's the delivery of a specialty area in medicine. Decades ago, anesthesiologists used to collaborate from, folks would used to say, from the golf course. And we noticed a lot of harm and deaths in the operating room. The anesthesiologist was not immediately available to rescue, what we call rescue the patient if they got into trouble. And that's how we came up with the national standard of being immediately available. Now, the issue about whether or not there's an anesthesiologist available in every operating room has always been an issue across the country. And that's where it came in, and anesthesia being a medical delivery of care, there is a surgeon there. There is a physician there to get a patient out of a medical emergency if it occurs. So the standard is that if there's not an anesthesiologist, the next physician is responsible for it. And that physician is usually the surgeon. That has always been the case. Our surgeons across the state know that. They've always known that. There are many who may not be happy with that because some of them will say, well, I don't know anesthesia, but you know how to save a patient in an emergency. Surgeons are trained in surgical airways, how to get a patient out of trouble if the issue becomes an emergency airway. We know that. We have seen that from reams of safety data across the country, which is why we have done that. Now, there is a bill that goes to the legislature every year to opt out, to make nurse anesthetists independent. The governor got a request several years ago, and you have a copy of that letter for an opt-out. After reviewing all the information that came to the governor, he said in his letter that he did not believe it was in the best interest from a safety standpoint to give an opt-out for independent practice. And so the only way you can get to independent practice is not through your ruling here at the board. It is for the legislature to change the law. Otherwise, the law is as it is, and you'll make your determination on that. And I'm sure the legislature will get another bill for them to look at this time. But that is the law in the state. And what I just wanted to do is make sure we're clarifying here that I don't know if you're being asked to change what the law is, but I don't think you have purview to do that. You have to go to the legislature and say that nurse anesthetists have independent practice. And the law does not allow that. Now, when you're saying collaboration, as has been pointed out, with three different disciplines coming on the APRN, and I know I'm dating myself, but I do remember when the term APRN came into play, and those three groups got lumped in under that, which is why at some point in time we had to get a declaratory opinion from the Attorney General about whether they had prescriptive authority. The Attorney General said that in the original language regulation, before they got lumped in under that definition, it was specific that CRNAs and nurse midwives did not need prescriptive authority. And then the opinion back from the Attorney General was, just because you changed the name does not change the reason behind the original ruling. And so that's how we have gotten here today, and it is confusing. I understand that it's confusing. But if you just go back to the original intent, you go back to where the legislature has said that there is no independent practice. You look at what the governor said when he had a concern about safety for the Mississippi public, without having position oversight of the anesthesia. I think that'll give you your question and help clarify all of this. And so I just wanted to bring some clarity to it because there are a number of things that's coming in here, and it is confusing. And I've been doing this for 3 decades, and I'm always having to sort of explain what it is, what the difference is, and what it all really means as far as where we are in the state with anesthesia services, across the country with services. And that's correct. There are states who have opted out, but there is a conscious decision about that. And then the law is changed to allow that. Thank you.
Thank you, Dr. Brunson. Could you please, excuse me, could you please clarify for me, again, just what is the state law on this issue?
That CRNAs do not have independent practice, and so they have to be under the direction of a physician or anesthesiologist.
Okay, thank you. Any questions or discussion for Dr. Brunson? Mr. Barnes?
That's not at this point, but Dr. Stout had asked to make a comment.
He covered everything. That's no problem.
Oh, okay.
If there are no other physicians who want to speak, there are a couple of points, questions really, or points I'd like to raise to the board, but Dr. Clayton looks like he's about to do it.
So I want to give the board a little bit of an explanation of why we're having this discussion today. It's in Mississippi statute, it says that other physicians besides a nurse, besides an anesthesiologist can collaborate with the CRNA. And that historically has happened, as Dr. Dotson brought up earlier, that she has been the collaborator for a CRNA during her cases. And admittedly, I have as well. For whatever reason, whether it be malpractice insurance coverage, or a feeling of uneasiness about being the collaborator, more and more often, surgeons are not willing to take on that role. And so that has created the issue where anesthesiologists have collaborated without being immediately available. So this issue has repeatedly come to the medical board, which means it comes to me. And I have held that if the surgeon is not willing to take responsibility, then the anesthesiologist must be immediately available. But since this issue and this topic continues to come up with more and more facilities, as the executive director, I need the board to give me guidance as to, am I to continue to go along the path I'm on, or does the board see it differently?
Okay, thank you, Dr. Cleveland. Mr. Barnes?
I just wanted to follow up on a couple of things that Dr. Cleveland said. As he mentioned, there's a statute that says a licensed physician can collaborate with a CRNA. The question, which we have discussed, the staff have discussed with Dr. Cleveland, and we've tried to research, does that mean any licensed physician? Because when we're talking about nurse practitioners, they have to have like practice. That is, the collaborating physician has to be qualified to collaborate. So shouldn't a physician, a surgeon, if it is, who is collaborating or is providing the supervision for that CRNA, does that position, should they not be qualified in the types of anesthesia? For example, a surgeon who only uses some level of mild, moderate, deep sedation, should he really, but he doesn't use general anesthesia, should he be supervising a CRNA if general anesthesia is going to be done? That raises obviously some serious questions. And so part of the discussion that we've had is, are there categorical answers to some of these questions as to whether is this particular licensed physician qualified and properly trained to supervise a CRNA for that particular type of anesthesia in that particular setting. The American Society of Anesthesiologists has reams of information available on its website, guidance, statements, and you have to be an anesthesiologist, I think, to consider them all together and I think what the Anesthesia Society is saying is exactly what was being discussed with Dr. Kirsch, that perhaps our regulations need to require or to clarify what the requirements are if a surgeon is going to collaborate. And it's really difficult if the board is in a position of saying, this is the standard of care, this is what our regulations require, but we know there's a bunch of people out there doing it differently, and we're just gonna, ignore it. That's obviously a dangerous situation. I don't have answers for you today. Y'all know I'm not a doctor, and I'm sure not an anesthesiologist. But what I do think is that this issue, just based on what the speakers here today, so the traditional standard of care and anesthesiologists immediately available, that is clear. The question of whether Mississippi, whether our regulations, the board's regulations need to be tweaked somehow to clarify is a question that needs study. And how they should be modified, if at all. It is complex. And I just have to admit to you that I don't think that Dr. Cleveland, with the staff that he has who are non-physicians, and that we have the qualifications to do that level of research and reporting to the board. And so I just wanted to suggest that perhaps the board consider forming a study group, a task force, call it what you will, but and appoint qualified people to that task force to research the issues and report back to the board. Obviously, I don't have a plan that I could suggest to you today, but one option would be to authorize the director to put together a plan for how such a task force could be created and people that would be on it. And it could be presented to the board perhaps at a later meeting in November or January. We have tried to research this so that we can provide good information to the board. And you've heard from several anesthesiologists here today, and there's a lot of information out there. But I just do not believe that we have the staff and Dr. Cleveland by himself are not enough to research this issue and to give the board all the information it needs to make the decisions. I'm not, downgrading us or talking bad about us. It's just simply a fact. So I would ask the board to consider giving the director authority to form a study group or to make a plan for a study group.
Thank you, Mr.
Dr.
Klein.
Lippincott,
Yes, Dr. Joyner.
a Hey, this is Tom Joyner. I agree that we need to get this to the appropriate committee, or we either need to form an ad hoc committee. This is a complicated situation that no matter what decision you make is going to affect the way that anesthesia and surgery is practiced across the state of Mississippi in the small hospitals. And so I think that's where we need to go with this. So that we can guide Dr. Cleveland in his discussion with other practitioners.
Thank you, Dr. Joyner.
Okay.
Dr. Kennard?
So I'm the chair of the Scope of Practice Committee and it's already formed. I don't know that Scope of Practice Committee, we have our research done. We have opposing sides. They have strong validation of their points. We've heard them. They're on the record. We know what professional societies stand by. We know what CMS stands by. The bottom line is the board doesn't exist to establish the standard of care generally. It does that in a mini courtroom session during a hearing, and we offer our own experts and we give the defendant a chance to do the same thing. Case by case. Yes, complaint driven. I think both sides substantiated themselves, but it's not the board's decision to wrap it all up and put a bow on it, in my opinion. So I'm board certified anesthesiologist. I've maintained that, practice pain management, did my training under Dr. Brunson at UMC. So what? I think if you just objectively look at it in a vacuum, we don't have the authority to tell you what you want to hear, like either side. We just simply don't. So we can go back into executive session and come out and tell you something or spend a few more months on it, but it's going to go to a higher body than this body. And we've got a lot of things to accomplish, and that's not that it's not worth our time. We just spent 2 hours listening carefully. So, we'll probably have to have some more discussions about it, but we have a Scope of Practice Committee already. Glad to take it up. I just see it as a little bit futile. And I'm sorry for that because I know everybody wants this guidance that Julie's looking for and everybody is. But this board's not the one to particularly give that specific guidance. We are to protect the citizens. We feel like we are. If we get a complaint that someone's at risk, we take it up. And we have a process to cover that already, but we can't supersede federal or state law. If we do, we go back to court ourselves at a higher level. So, I mean, thank you for entertaining and humoring my opinion, but I understand all the terminology, even though I haven't practiced general anesthesia so much. I get what we're doing here and what we're trying to accomplish, and this board can't simply accomplish it, in my opinion. Thank you.
Thanks, Dr. Kennard. Any other discussion? Yes, Dr. Dotson.
Thank you, Dr. Kennard, for your thoughts on that. As a board member, I'm going to respectfully disagree with a portion of that because, as you state, we do have a Scope of Practice Committee available to us, and I do think that it is worthy of serious discussion within that committee, and that some recommendation be made to the larger board as to our options. I am of the opinion that there are very, very few situations where I have no options. I can choose not to act, but usually there are options available. And I think it is incumbent on us, and it is our duty to explore all of those options and then present them to the larger board. As I see it, we are the backstop in this state for the things that govern medicine and the practice of medicine. So for us just to yield and say summarily that it cannot be done, I have a problem with that. So I think that in my opinion, it is definitely worth sending it to the scope of practice committee and doing our due diligence. And then if we come out of that committee with recommendations that there is no action required, then I think that we have done our duty to the positions in the state and also to the people in the state.
I wholeheartedly agree with that.
Dr. Owens had her hand up and she's taking it back down, so I don't know if she wants to be recognized or not. Oh, she disappeared.
Ken?
Any word from, Dr. Bernard?
Yeah, so that was a lot of personal from me, and I know we're not really supposed to do that, but it got us to the point where you were able to respond and say that I think it is important. I'm glad to take it up, try to bring some clarity. So, yeah, I mean, I agree with you. We have a duty to do, I'm not speaking for the whole board. I just wanted to give you my perspective, and now you've made your recommendation. I think that's sensible. Whether or not it results in more satisfaction to anybody else, we shall see, but glad to. Thank you.
Thanks, Dr. Kennard. Dr. Owens, we noticed you had some comments, so is there anything that you would like to say?
My connection is a little weird, so I don't even know if you can even hear me. Can you hear me?
Yes. Yes, we hear you. Can you hear us?
Yeah, it's kind of going in and out. I guess I'll have to reserve my comments for a later time. I'm sure we'll have additional time to talk, but I don't know if you guys can hear me. I'm having a little difficulty hearing you right now. Sorry.
Well, we got your comment that surgeons aren't necessarily in the same or similar practices.
Yeah, I think so. I'm going to just give this a shot. So there's been a lot of really good discussion. I think it started out really kind of focusing on CRNAs in general. And I think the whole issue of collaboration being done by any physician, I mean, the concept that any physician is sufficient, I think is a question. And we've had some of our anesthesiology colleagues come in and very eloquently talk about how, you know, the timeliness matters, the choice of medications and all of those things, and general anesthesia and all these other options. And I just know I've been in situations where, you know, I've been that person, and I did not go into the situation knowing that I was going to be collaborating with a nurse anesthetist, and was not even in a position where if something had happened to the airway that I could have responded as the person who's also performing the surgery. So I think it is more nuanced. While I appreciate my colleague, Dr. Kennard's position, I do believe that there is a place for the board to weigh in. It doesn't have to be the end all be all. As I said, as you've heard, like, you know, the governor has an opportunity to weigh in on some of these things, and the whole opt in, opt out, and all these other options that are available. But
Sorry, we just lost you, Dr. Owens. Thank you for your comments. Do we have any other comments, questions, or discussion on this issue? Do we, if not, I would entertain a motion if anyone has one.
Yeah, I agree. I think we need to make a motion. We need to send this back to your committee and see what we can kind of get.
We have a motion to. We have a motion to refer this matter to the scope of practice committee. Do we have a second?
I second it.
Which committee was this?
Scope of practice.
Can I offer an amendment to that?
Dr.
All right.
Dodson? Yep.
Dr. Loper just made a motion to send it back to the scope of practice committee.
Or to it, period.
To the scope of practice committee for further review. I would like to add an amendment to that the executive director also be authorized to augment that committee where needed for special expertise to do additional research or any other information that's needed to gather.
Absolutely. We have a
like
second.
that. I second that as well. That's good. That's smart.
We have an amendment to the motion, and a second. Any further discussion? All in favor of the motion, to refer back to the scope of practice committee as amended, with, special expertise for Dr. Cleveland, say aye.
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 Uh,
Let's see, all opposed, say nay.
Did you get Dr. Owens? She off? Can she vote on the messaging?
I don't think Dr. Owens can hear us.
Oh, okay.
Yes, and she said yes.
All right, fair enough. I got it. I have to describe this, so I need to know.
We got you, Dr. Owens, we got your vote. All opposed? Any opposed, say aye. Any abstentions? The motion is passed. It's now, 11:27, and, I have information that, lunch is to be delivered at 11:30. I would entertain that.
We might have one quick.
Do we have, any further,
It's not gonna be quick.
do we have any further quick business before lunch?
We do not.
Well, do I need a motion to adjourn for lunch? We
What time
will,
would you like us to be back?
I think we will, resume the meeting at, would 12:30 be okay? We're in recess for lunch till 12:30. are, Mr. Ryan Hebert or Abear, Marcus Montanet, MP, regarding, a request for an exception of Rule 1.4 extended mileage for collaboration with nurse practitioners.
And just for clarification, from board members, this group came before the executive committee, in July, and the executive committee, denied their request for exception. They wanted to return, it's the right to present, make their presentation to the entire board.
I appreciate the opportunity today. Thank y'all for having us. I'm an interventional cardiologist in Meridian,
Could you
Mississippi.
identify yourself,
Yes,
please?
I'm sorry. I'm Dr. Wesley Bennett. I'm an interventional cardiologist from Meridian, Mississippi. And we're members of a company, Cardiovascular Institute of the South, that's based in Houma, Louisiana. And part of the company is a virtual care center that's located in Lafayette, Louisiana. And they have advanced practice RNs who cover our practice from 6 p.m. at night until 6 a.m. in the morning. And they're basically a virtual care provider for questions that arise from patients in the hospital and from patients that call from outside the hospital. So their place of practice in Meridian is at Anderson Regional Medical Center. And they are providing virtual care for our patients after hours, more or less. And I wanted to get our CEO, Ryan Abear, come and speak with you. And then we have our clinical director, Marcus Monte, who is much more versed in collaborative agreements. We all 7 signed a collaborative agreement with the APRNs that are down in Lafayette. And of course, we're looking for an exception related to the 75-mile rule so that they can provide after-hour services for us. And if you have any specific questions for me, I'm happy to answer them, but I think our 2 guests would be able to much more effectively provide you with the information and the details related to the collaborative agreement that we exercised through the virtual care center in Lafayette.
Dr. Bennett?
Dr. Watts, I'd like to ask you a question. You said they provide inpatient, nighttime, they're your on-call people at night?
They're on call, accepting phone calls from the nursing services on the floor for questions that arise related to our patients.
Just a question of clarification. If it requires more than that, do y'all have someone who?
Oh, yeah, yes, we're all on call. We have people who are physically available in the event that someone needs to be seen. And we collaborate with the APRNs related to whether that needs to be done, and fairly frequently get calls from these RNs related to questions that arise or problems that are arising that we deal with by getting it up and going to the hospital to see patients. We need to.
And I assume y'all are on the same EHRs, right? Because they have access to all that.
Yes, they can access, and Marcus can go through that in some detail related to access to our records and our availability for that.
So, Dr. Bennett, thank you. And I just had a question, clarify for me, where exactly are you located? Where are you located?
Yeah, we're in Meridian, Mississippi. Our physical address, gosh, I don't even know. It's much like asking me my phone number. I don't know that either.
That's not important, but,
Yeah.
And where are the nurse practitioners located?
The nurse practitioners are located in Lafayette, Louisiana.
Okay.
That's 316 miles away. That's more than 75 miles.
That's pretty good.
And the patients are in Louisiana.
No, sir, they're in our hospital in our community.
So the
Admitted to our service.
nurse practitioners are in Lafayette, Louisiana, and they're treating the patients here in Mississippi.
With virtual care, basically care that's provided over the telephone related to the ability to review the records and review lab data and any questions that they have directed that should be directed to someone above their level of comfort with caring for the patient, they call us. And so That's how that's managed.
I'm a little confused, I think. What, don't you have nurse practitioners in Mississippi?
We do, but we, as a part of this company, we can save some of the trouble related to trying to hire additional nighttime services that can provide that locally.
So where are the patients located?
Patients are in Meridian, Mississippi.
So if there's a problem, are you available to see the patient?
Yes.
Okay, that's all the questions I got. Do we have any other questions for Dr. Bennett?
They have a presentation.
Yeah, okay, thank you.
Yeah, so I was gonna get
Thank you,
my
Dr. Bennett.
CEO, Ryan Aber, to come up.
And Dr. Lippincott, I misspoke. The executive committee voted to table the decision on the request.
Yes,
They did not deny it.
that's recorded in the minutes.
Yes, sir. I reviewed that and realized I had missed it.
Good afternoon. Thank you for letting me join y'all. My name is Ryan Aber. I'm the Chief Executive Officer for Cardiovascular Institute of the South. If you give me just a second, I do have some slides. I'd like to kind of elaborate a little bit more on what Dr. Bennett was saying, give you a little bit more insight into who we are as an organization.
I think they just hit the button.
Give you a little bit more insight into who we are as an organization and kind of maybe give you a little bit more of a summary of how this program works.
Excuse me just for a second, Mr. Aber. Dr. Gurr stepped out for a minute. Do we need to wait on him to come back or?
I don't think so.
Okay.
This is not a
No.
licensure hearing.
Okay. Okay, yeah, thank you, Mr. Aber.
Yeah, sure, we could, not a problem. I don't mind waiting if you, yeah, okay. Well, very good. We'll give you a little bit of insight into our program, because it's a little bit more than, why we came about with the virtual care center. You're not gonna throw that at me, right? See a lot of swinging going on here.
Now, our president just re-arrived, so.
It's okay.
I promise you guys, I'm gonna be easy here.
It's, we're doing the relay thing and trying to do the handoff.
I understand. So just to give you a little bit of insight into why the virtual care center came into concept is that we started our practice 41 years ago. It was before my time, but I will just say 41 years ago, the practice started. And we started in Houma, Louisiana, and we've expanded. If you look at the footprint, we are basically cover most of Louisiana. And then through just sort of a growth opportunity, we combined with Dr. Bennett and the Meridian cardiologist and expanded our practice footprint into Meridian, Mississippi. And we also have, believe it or not, practices in Illinois, in the suburbs of Chicago. Now, the reason for that is our model's a little different. We're a private practice group that basically creates a collaboration with the hospital. So we actually manage the cardiology service line for the hospital program. And what that means is that we basically control the rounding. We basically work on all of the floors and ensuring that patients receive quality patient care from a cardiovascular service line, provide all the interventional services in these programs. We do have, if you look in here, this is just sort of a footprint of how big we are. We have 62 physicians, interventionalists, 53 APNs, a little over 1,100 employees now, 22 clinic locations. This is all the stuff we have in the South. And telecardiology. Now, why is all that sort of basis? Our program is, and one of the things we pride ourselves is we basically strive on how we're going to provide higher quality services. There's a lot of different business models out there. There's a lot of things that you can focus on how we're going to make additional dollars. And the virtual care center was actually a quality driven program. And the reason for that is we recognized a few things that were associated with quality. And one was keeping our physicians healthy. When you think about physicians and the well-being, one of the biggest burdens that comes with docs, and all the docs that are in here can probably acknowledge this, is that the night call generally can become very burdensome, especially when you're providing different levels of care. Well, so the concept of virtual care came is how can we give the docs some relief at night so that they can provide quality services both for the patients at night that needed specific acute care, as well as those the next day that are going to require further care, whether it's in the clinic or the hospital segment. So the concept here with the virtual care center is something we invested in. Wasn't a big money deal. We put the money into it. We'll highlight what the program looks like, but it was specifically designed in order to try to take some of the routine calls. You know, does the patient need an aspirin? Does the patient need something for a small relief of pain? Those types of things off of the doctor's call burden and put it on a nurse practitioner that's awake, designated at night to take these calls. Now, to do so, we had to set it up in a format where they had access to the EHRs, which we have access to the EHRs. We had to collaborate with all the physicians. We had to make sure that there was a process in order to ensure quality was controlled at all times. This was an investment. Hospitals don't pay for it, nothing. We did this because we wanted to keep our doctors, our physicians, healthy from a perspective of not having to call. Average age of a cardiologist burnout is 55. We have doctors now that are in their 60s, some in their 70s that are still working because they don't have as much of a burden with the call. So we want to continue to expand that service into the Meridian market with this virtual care center program platform. So the virtual care center was an investment. We started in 2015. We built it in Lafayette, Louisiana. A lot of that is because it seems like Terrebonne Parish, which is where we started, is the center of where all the hurricanes come in. Last time I talked to Dr. Cleveland, it was 2 hours before we got hit by Hurricane Francine last week or 2 weeks ago. So it's been, it certainly was an ideal location for us to hub it. We basically have 24/7 patient access that occurs. We have it's staffed with APNs, RNs, we have telemetry techs, LPNs, all within the center. And again, the whole thing is dedicated to managing patient issues that are associated with this. And we also have state-of-the-art technology. We have some innovative ways. Now, if we needed to advance it where we have virtual care telecardiology services, we can do that. We do that for certain locations or rural access centers. But that's not what's needed here, because what we basically do is we support the physicians for this particular market in Meridian at Baptist Anderson Regional Medical Center. The nurses call. If it's an acute event where it's sort of STEMI that requires or a heart attack type scenario or distress scenario, it immediately gets sent to the physician on call. But if it's something that's standard that can be handled by the scope of practice of the APN, it's handled at that time. So what do we do with the virtual care center? This is the things that we've learned. It's to handle nocturnal call. We also work to reduce expenses to the taxpayers by doing transitional and principal care management, which reduces ER visits in hospital. We do also offer some remote services, again, to reduce the patient's discomfort. But the main reason we're talking today is really about how do we help relief on the nocturnal call piece. So here's a little bit of just a video, and as the video is going, I'm going to transition to Marcus, who can give you insights into how the virtual care center program works, unless there's further questions from me at this time. So this is the facility. Basically, the nurse practitioner has their own spot, 4 screens. You can kind of see the layout. We have a whole team. It's kind of a little bit like a NASA Space Center. We wanted to have it something special and unique. This is not something you see everywhere. It is unique to us. It is something a lot of people are working to do to transform. What we say is transforming healthcare and have access to that exists. Any questions?
Thank you, Mr. Hebert. Any questions for Mr. Hebert?
Yes, sir.
How do you monitor your nurse practitioner's care and how do you train them?
Yes, sir. Thank you. So I can answer that question in some detail, but I'm also going to invite Marcus, who is actually the head of our program and is a nurse practitioner. As far as in the training, there is a competency profile that they do. We also have a quality initiative program that we run. As we go a little bit further through the presentation, he's going to outline how we monitor their quality controls and to create the collaboration of a review with the physicians to ensure that the program is successful. We do have a process in place to do that. And again, he'll be able to highlight that a little bit more in the next couple slides, if you're okay with me deferring that to him for the next segment.
We'll see how long.
We'll see.
No pressure.
We'll see. No other questions? Either I did a good job or that gavel's coming at me. Thank y'all. I'll let Marcus take over.
So my name is Marcus Monte. I'm a nurse practitioner, and our senior director of clinical, operations at CIS. I've been with CIS for 13 years, so we've been around with CIS for quite a while and actually have, been instrumental in the start of the virtual care center, providing access to patient care, relieving our docs, of that service at night, and needed when they're needed, available. So I hope to answer your questions as well. So obviously, to kind of further engage in your question as well, our nocturnal team, our night team is made up of these three nurse practitioners, all with significant amount of years of experience within the cardiovascular space. These are not new APNs. We do not put the new APNs in this space, and so they are quite experienced in making sure that they are well-rounded, both from the hospital side of things as well as the clinic side of aspect of care. And so as you can see, our first one is 29 years of experience, followed by 23, followed by 10. They work from a 6 p to 6 a.m. 12-hour shift scenario. They have access to the EHR of every hospital that we service, as well as our own clinical EHR. So they have all of the access to all of the knowledge and information that the patients are required, or that our APNs are required, so that we can provide adequate care at the nighttime hours. These three are also Mississippi board licensed, as well as collaborating with all of our Mississippi physicians as well across the board. This is our nocturnal footprint. So this is currently where we have call coverage for our hospital systems. As you can see, the footprint in Louisiana, and then what our aim is to have that same aspect be covered in Anderson Regional, which is the one in Circle. The workflow for the nocturnal call flow process, if you will. So if a hospital staff member wants to reach out and contact the cardiologist and or the nurse practitioner, all they have to do is dial our Meridian phone line. You don't have to remember some special line. It's easy for them. It's not a separate line that it reaches out to this location. The call is immediately transferred to the APN. Once the APN reviews that chart, discuss with the hospital staff, maybe it's the ER physician, whatever the call comes about, the APN documents within the EHR of that software, whichever, or that hospital, as well as documents in a software that communicates care and continuity of care to our nurse practitioners who would potentially be rounding in the hospital for the next day. So continuity of care continues to happen across the board. Once that call is finished and wrapped up, our APRN will be listed on a tracking method for quality assurance, and I'll show you that here shortly. Another aspect in the continuity of care, kind of revolving the whole entire system from day to night and night to day. The hospital call comes in. If it is a high acuity care issue, that call will be directed straight to the physician, bypassing the APRN. If it is something that is not acute and low level within the scope of the APRN, it will be handled by the virtual care center. The patient, or I'm sorry, the EHR will be documented within, as well as in the software that we can communicate with our staff as well, who are coming in on the following shift, day shift. The day shift also will document within the EHR, obviously within the hospital, and can also document it within our EHR software system that communicates a transition of care and the handoff to care. So that everyone is communicated and we're well informed of what's happening with those patients. Additionally, what we also do outside of the nighttime shift, 6 p to 6 a, we also provide access to 24/7 care. So we want to provide access care for Meridian patients, Mississippi patients, from 6 a to 6 p, both on the weekday and on the weekend. So we have nurse practitioners, including myself, with years of experience in this field, the access to these patients, so that when a patient calls in from the home setting, the nurse calls the Meridian office, dials that Meridian phone line, then our nurses will triage that patient, direct it to the virtual care center APN or the local APNs if need be, and we'll address the patient's need for care or concern. And so providing the access to care 24/7 so that we can actually have these patients appropriately cared for in a short time frame. This is the day workflow. It's not much different than the night flow. The patient calls the Meridian clinic. The nurse will triage it, address it or send it over to the nurse practitioner. Nurse practitioner will address what the patient's concerns are, review the EHR, document within the EHR, and then they also, because he had involvement in that patient's care, will document it on the tracking form, which I'll show you shortly. Obviously, we want to practice with guidelines. The ACC/AHA guidelines, which are recommended for cardiology, is what we follow and continue to follow. We specifically design guidelines for atrial fib, atrial flutter, angina, congestive heart failure, and the prescribing of amiodarone. So key performance indicators and how we address and identify we're following suit and preparing or providing patient care by our physician standard as well as you guys' standards. So we are currently where we sit and take call for biannually, we are at least doing doing chart audits at least at 3 facilities every year. We are also monitoring door to balloon times, which basically means are we effectively engaging in the STEMI or myocardial infarctions that come in through our EHR, and within the 90-minute time frame nationally that's suggested, are we meeting those requirements? Also, we have recorded calls for quality assurance, and then more specifically, monthly chart reviews for 10% or 20 charts, whichever is the lesser, are being reviewed by our physicians, and then quarterly MD reviews with our APRNs, so that we can do that via Zoom, and we're identifying that if any additional conversation or additional care or different changes need to be had, that they're being addressed at that time. Some other quality initiatives that we are part of that we pride ourselves on as well is our hypertensive control for the past 3 years and longer, and we're waiting to get word on the 2023. We've had Go Plus awards on our hypertension management, as well as Gold awards for our vascular statin therapy for PAD, dyslipidemia, PAD, those types of things. So we are priding ourselves on these quality measures. So here's our quality assurance tracking form of how we plan to track and satisfy the medical board's review, and that we're providing these quality assurance to our nurse practitioners by our physicians. And all of these locations or these columns are expandable, but basically what you see here is the date that the service was provided by the APRN, the medical record number, which APRN was providing that service, the location of where that APRN addressed that patient at. Was it in the home setting? Was it in the hospital setting? Did the patient need documentation within that EHR? And then they kind of elaborate a little bit about what was the plan of care, what did they do, how did they assess the patient and involve the patient treatment plan. And then the black line separates where the data review occurs. So the physicians obviously are monitoring or managing and reviewing these charts monthly. Which physician was reviewing it, as well as their comment, again, also expandable. So if they want to add more in detail, we can definitely have that there. As well as the quarterly reviews, which physicians were involved, who was present, what date did that occur, and the comments that were coming out of that meeting. This physician gateway is just a snippet of Dr. Bennett's actually gateway that shows all of the protocols that we've created for the 75-mile exemption, as well as the explanation and the letter of why we want this exemption. So it's basically just showing that we were uploading all of our protocols to each physician's gateway so that everything is kosher and standing, good standing. This is just a snapshot of our nursing board gateway for each nurse practitioner. It's similar to the physician's gateway. And I know in the previous meeting that we had the question of whether or not the physician's physical location of address was correct. So what we've also done is change the nurse practitioner's physical address of where they're physically located, 2730 Ambassador Caffrey in Lafayette, Louisiana, to reflect that on the physician's gateway of where each one of the nurse practitioners who are within the virtual care center are physically located from that address site. And so with the nursing board, we actually, myself, met with Dr. Cagle at the board and their counsel, and also confirmed that the addresses were appropriately aligned on how they see fit as well. So the actions taken since our last meeting
several, per the board's request. That the addresses were changed, as I've just mentioned, on all of the gateways, the physicians gateways settings. An in-person meeting was had with the nursing board of nursing, the nursing board, so that we could get our approval of collaboration and how our functionality was happening, as well as the physical address scenario. We have established our Mississippi Collaborative Practice Protocol, which includes all of our signatures for the purpose of the extended mileage collaboration rule, which ensures the backup and emergency coverage for when one physician is maybe unavailable. We have a second one to repeat and to reach out to. It outlines the quality improvement initiative with the review of 10% or 20 charts, whichever is the lesser. Ensures the maintenance and logging of charts with all of the names and details that I just provided just recently. And then also providing quarterly meetings with the collaborators, the physicians, and the APRNs who are remotely located in Lafayette. As well as the collaborative practice protocols have all been uploaded to the Mississippi Gateway Physicians logins. I'll take any questions.
Oh, well, I'm not.
Thank you, Mr. Monte. Questions?
Okay, I have a question. So you said your physician from Anderson talks to your nurse practitioner. So if that person is going to be admitted, you have someone physically admit that patient, or do they just sit in wherever they sit all night to somebody, the cardiologist sees them in the morning? How does that work?
So I can answer that. Yeah, chime in as well. So we're typically not admitting from the ER. We're consulting in the majority of our cases, especially through the ER. In most cases, we're consulting. So if the if the ER physician has a question and says, the internist says, okay, I'll admit them to my service, we'll admit them to the floor, but look, their heart rates in the 130s. Right. What do you suggest we provide so that we can address their heart rate?
Well, I would tell you that my choice and my request would be that they call me for admissions. I don't think that for practitioners should be, that's just my own preference, and I think it's the preference of all 7 of us would be, I routinely get calls for admissions. So it's unlikely that they should get admission. So, sure. The question was, when a patient's in the emergency room and needs to be admitted, that's something that is directed to the physicians and not to.
Okay, so that's coming, you are talking to that ER doctor
yes.
at some point. Okay. Right.
And I don't know of any instance, to my knowledge, I don't think that it's occurred in any other way. Okay. Thank you.
Any further questions or discussion?
I have one. So, with this model, because the question's been asked about admissions, how exactly is it determined when this entity is first called versus when it's not? Who makes that determination?
Sure. So when the hospital calls, let's say from the ER perspective, Dr. Cleveland actually asked me the same question, and it's a great question. So anytime an emergency situation, a high acuity, and more times than not, it's the ER physicians that are making this call, right? It's not the staff or the nurses. The ER staff has been trained that if there's a STEMI or myocardial infarction or a cardiac emergency, those calls directly go to Dr. Bennett and the other Meridian physicians, and do not get entertained by the APN at all. Should one of those calls be transferred to the APN inappropriately, we'll obviously divert that back to the physician. That rarely occurs, if ever, and we have been sure that if there's any delay, or that there is no delay, let's go with that, because that we have an immediate access to their physician line, cell phone, who they're all aware that they're on call. So the ER is directing how that call is going to be addressed. If they say they want to speak to the provider or the physician, that goes directly to the physician.
So then is the answer that the ER person determines whether you guys get called or the cardiologist gets called?
So for the majority of our calls, I mean, obviously the acuity of the calls are not always highest of the acuity that require the immediate urgency of the physician. So what happens is if the call goes directly to the nurse practitioner in more cases than not, when those calls come in for STEMIs or myocardial infarctions, where timing is a urgency, those calls directly go to the physician's hands down 100% of the time.
So then if there was a policy, recognizing that no one particular policy is going to be all inclusive, but if there was one, then essentially what you're saying is those things that would require intervention would immediately go to the cardiologist. I guess my question is, so say I don't need to go to the cath lab, but I still need to be admitted to the hospital for a cardiac condition. Then who is doing that?
Yeah, so if there's any questionable decision on whether or not that has to go to the physician or not, that'll go through our nurse practitioners, who obviously are well qualified and highly experienced. And if they feel as though it's above their scope, it's something that needs to be addressed by the physician, that will go directly to or we'll send that directly to the physician through the nurse practitioner.
So when we had this conversation before, it was my understanding that y'all educate the staff at Anderson that if they want to request MD only call, that they can do that. Is that correct?
That is correct.
That would be my preference.
Right. I mean, so I think what Dr. Owens is asking, this is why I brought it up during our pre-meeting of the meeting, I guess. You want to eliminate as many steps as possible. And if the call is going down to Louisiana first and then having to be routed back to Meridian, then there's room for error there. Right. And so that's why I thought it was important that y'all make it very abundantly clear to the board that the staff at Anderson is educated on how to not end up in the call center. Right. So
that is actually correct. Yes. So we educate the staff in Anderson, both the ER and the floor, with our nurse practitioners on the ground, as well as our physicians who are rounding in the hospitals, that if any call, it shouldn't be going directly to the physician, that is what is requested, and that will go directly to our physicians for all calls.
It's been our experience. I think it's just important to add, through our experience, as you see, we've done this in South Louisiana. The majority of the calls that come through are actually the nursing team calling about a patient order that is basically looking for general, non-acute, non-distress related orders for a patient. They may have some discomfort in the evening. It's something that's not necessarily that requires the interventional cardiologist to be directly. It's in the scope of the practice of the APRNs. That's what we kind of identified 95% of the calls that we were getting were those types of calls. It's the other 5% that I think we're talking about here. And that's where we educate the staff. We make sure that the protocols are in place, that they identify, I need to speak, I have an emergency event here, which immediately gets directed to the physician that's on call.
Thank you. Any further? Mr. Braylon.
Question.
Cut your mic on, please.
Are there, steps,
Yeah, there you go.
are there cardiologists practicing in Meridian, licensed in the state of Mississippi?
Yeah, Dr. Bennett right here is one of them. So this is.
Yeah. But do you see patients in Meridian
Yes, sir.
every day?
Yes.
Every day?
Well, Monday through Friday.
Well, I mean, when you're working, your workstation is in Meridian.
Yes.
Okay, well, I must be missing something then.
So essentially what's happening here is the nurse practitioner virtual care center is just serving as an extension of the cardiologists that are in Meridian. So the Meridian physicians are providing the interventional cardiology services, and they're providing the care, both acute as well as standard of care protocols. When there is an issue that exists, or actually let me rephrase, but come 6 p.m. at night to reduce some of the call burden, the standard call that the nurse practitioners can handle, What we basically do is have somebody who's dedicated at night, that's awake, that has access to the charts to be able to serve as an extension to answer the standard, basic, non-acute related questions. And that the nurses are orders that may be needed. In the event that there is an emergency, which is less than 5% of the time, then the interventional cardiologists, the guys who are on call every night, are available to go provide those therapies and those services. So the virtual care center is basically serving as an extension of the interventional cardiologist in the market. It's a helping hand, basically.
Thank you.
One more question. That makes another question. You have a cardiologist that rounds on inpatients on the weekend?
Yes.
Okay, so you're not just letting the nurse practitioner do all the rounding on the weekends, okay?
I have a question, so the request is for an exception to the 75-mile-an-hour rule for the 3 nurse practitioners in Lafayette.
So we have 8 total.
8 total?
Yes.
Okay, and I noticed you've got several backup physicians in Lafayette. You've got, what, 3 backup cardiologists in Meridian, is that correct? Physicians?
We have 7 physicians in Meridian.
Okay.
Yes, who are all backup, who are all collaborated with our 8 nurse practitioners in Louisiana, with the Mississippi.
And you didn't have to list the nurse practitioners in Meridian, but I assume you have nurse practitioners in Meridian as well. Okay, I think we got enough information, unless there are any more questions. Any comments? Any further comments or discussion?
Who reviews the quality on nuclear medicine? Is it the Mississippi physicians or is it?
Yes, our Mississippi physicians will be the ones that will be reviewing specifically for AIMS.
How do your nurse practitioners get CME?
A variety of ways, but all approved and have to be submitted to their board as well.
Well, I would like to.
I have a question.
Oh, Dr. Owens.
I'm lit up again. Mr. Bennett, I'm sorry, Dr. Bennett, question. For your group, since the number or statistic was given from people who actually done some analysis, about 95% of their calls being small general calls and not significant. Has that been your experience from what you and your partners are seeing when you get phone calls from Meridian? Because I mean, different location,
Yes.
maybe be a different patient population. I'm just wondering if that's kind of been your experience, that 95% of your phone calls are kind of just, hey, Miss Jones needs Tylenol.
Right. But one of my pet peeves is when someone comes in with an acute MI, they check troponins. Somebody with an acute MI is going to have elevated troponins. Invariably, 3 hours later, they're going to call me. I've just done an intervention on this patient and opened a coronary artery. And they call me 3 hours later to tell me that their troponin is elevated. I knew that already. I had taken care of the patient. You know what I'm saying? There's a lot of that sort of thing that happens. I take the call and I say, thank you, and I hang up, but that's a totally unnecessary call. It's kind of like in a surgeon who had just taken out an appendix emergently, being called 3 hours later to be told the patient doesn't have an appendix. Kind of similar to that. So you wonder why they call you those sorts of things. And their hematocrits of 28 at 4 o'clock in the morning, potassium level of 3.4 at 4 o'clock in the morning when you're going to be rounding at 6:15. Things like that, that become irritating. And you can't go back to sleep because you're so irritated. That happens.
Madam President,
Yes, sir.
or whoever it is.
I love that you said madam and he said yes.
Don't answer that. Okay, let me get to my question before you, all right. No, I'm glad you brought up those 2 hypotheticals, Dr. Bennett, because where I was in the mix was you got an ER physician and their staff of nurses, and then you got hospitals, most places now, and a larger hospital, I'm sure Anderson has them, to handle the mundane, which should be taking that off of your plate. I do understand we live in the real world and the hot potatoes passed of liability. And who's gonna step up and actually make the call and have their insurance company
Right.
defend them. So those two hypotheticals you gave outside of what I could see should have been handled by the staff that was paid to be there that shift.
Yeah.
Those are important. So it gave me some clarity as to some other types of calls you could receive that
Yeah.
aren't appropriate then to go back to the ER physician because he did post-intervention. It's yours.
Right.
Okay. That's good. I just wanted to state that I was a little confused at the beginning as to why the mundane wasn't held by what we've always done
Right.
typically. And then when you're called by the ER, it's because
Right.
it's not mundane anymore.
That's right.
Okay.
Yeah, I'd like to thank Dr. Bennett and Mr. Abear and Mr.
Dr.
Monte
Lippick,
clarifying and,
Wait a minute. Dr. Joyner
Oh.
has his hand raised.
oh, sorry.
That's what that little thing up there was.
Oh,
sorry, guys.
Dr. Joyner,
My question is this, most of the time when we bend the rules on the mileage and on the nurse practitioner situation, it's because we're dealing with an area that is short on that type of service. In other words, they might not have cardiologists or they might not have surgeons. And so we will sometimes bend the rules in that direction. This is not that situation, if I'm reading this correct. This is a situation where the cardiologists are actually in Meridian. We're not going to be increasing the service inside of Meridian. The nurse practitioners are going to be located out of the state, which we try to avoid. We try to avoid that. And the only thing that I have understood as we've gone through this discussion is we're trying to get more rest at night. What am I missing here?
So if I can take that with, Dr. Joyner. One of the things to a point that you made in the very beginning about, yes, we do have the service today in Meridian. We do have some resources, but one of the reason that we have those resources is that, and this exists in our Louisiana, is being able to extend some of these physicians who are practicing their level of being able to attentively take care of patients in the market. What I mean by that is that, and I mean, no offense by this, but some of our guys are getting in the tenure of their career. Call could definitely become a challenge to manage as they reach that tenure of their career. And one thing about the Meridian market is that it has been very difficult to recruit new physicians to that particular market. We have been doing so actively for about 6 years now, trying to get new physicians interested from an interventional perspective. And I will tell you that we're making every attempt to do so. However, it has been a challenge. We have not had a lot of interest in coming into that particular market. So by doing this particular entity, what we're able to do is extend some of the time and the length of the services that are being provided by some of our tenure physicians in taking call and still managing the patients within the market. If we have a tendency to not be able to do that, continue to provide that lift, we're going to end up with a pretty significant shortage here shortly, because I do have some physicians that are in the retirement age, but are continuing to elect to work if they have this as an option.
thank you. Any further questions or discussion? If not, do we have a motion?
I move that we leave this session to consider going into executive session to discuss this matter.
Dr. Joyner, do we have a second?
Second,
We have a motion and a second. Do we have a, all in
to
favor?
close the meeting to consider whether to go into executive session.
Exactly. All in favor, say aye.
Aye.
Opposed? Any abstentions? The motion, do we have any further discussion about going into executive session?
We've done that before we voted.
Yes. The motion is passed. So the meeting is closed. will, announce the board's decision.
Board's decision is to deny the request for the waiver and further increase to the executive director should be made regarding the matter.
Thank you, thank you, Dr. Bernard. The next item on the agenda is a request for a declaratory opinion regarding whether a physician may delegate administration of medication to medical assistants or other unlicensed assisted personnel.
So Mike, this is one of those situations where we have three matters that need to be conducted in executive session. And I, you know, again, to cut down on the amount of back and forth, I think we can do this. We just need to be, the record needs to be clear that we're gonna, I need to give you a proper reason for number 15, 16, and 17 to go into executive session, then close the meeting, vote for each one to approve it, and then handle all of these in the executive conference room without having to come back and forth. If the president would and the hearing officer would permit us to do that.
So can we take care of these three matters in one executive session?
That's what I'm saying. We just have to make sure that the
You succinctly state what each one involves and make the announcement that it's a true determination to go into executive session.
So for item 15, the request for declaratory opinion, the basis would be section 2541(7)(4)(b) regarding the potential issuance of an appealable order. For item 16, the investigative subpoenas, the basis for going into executive session would be 2541(7)(4)(d), which are for investigative proceedings. For our agenda item 17, a matter for review and discussion to be held in executive session. And again, the agenda is incorrect, and that's my fault for not properly proofreading, but it is for a report from counsel to the board on existing litigation, which is 2541(7)(4)(b) also. So those are the reasons that I believe those are all legitimate reasons for the board to go into executive session on each of these items.
So, I would move that we close the meeting to consider whether to go into executive session on the three agenda items that have been presented. Item 15, 16, and 17 as stated by Mr. Barnes.
Thank you, Dr. Owens. We have a motion. Do we have a second? Second. We have a motion and a second. Any discussion? We're going to consider going into executive session. All in favor of the motion, say aye. Aye. Any opposed? Say nay. Any abstentions? If not, the motion carries. And the board is, the meeting is closed. And, Dr. Kennard is going to, announce the, boards on these three items.
Yes, item, sorry. Item 15. We, after review and discussion, there was no action taken on item 15. On item 16, after discussion, we approved the requested subpoena. Item 17, after discussion, there was also no action taken.
Thank you, Dr. Kennard. Item 18, Dr. Zalzala. We have a consent order.
Yes, and it's on your, should be in your materials, and also have, hard copies of them, like, pass it out, but it's similar. We've been calling it Zala, I don't know if that's right or not. Dr. Zal, this is a mirror action, related to, discipline Dr. Zalzala received in the state of Missouri. And subsequently have learned that Dr. Zalzala also got in trouble for a very similar issue in Maine, and he's gotten some other mirror actions. Essentially, Dr. Zalzala was practicing telemedicine without doing physical examinations of patients and issuing them prescriptions. And that's what Missouri disciplined for. Also, Missouri's collaboration rules require that before a physician and a mid-level can collaborate at remote locations, they must practice together at the same location for at least 1 month. He did not do, the nurse practitioner did not do that. So the Missouri board has the Missouri order is in your materials also, some more detailed requirements. But the primary discipline was a public reprimand. And so the consent order, which we offered to Dr. Zalzala and which he has signed, again, is for a public reprimand, that he comply with all of the requirements of the Missouri disciplinary order, and that he reimbursed this board's costs, and that he submit documentation showing that he has fulfilled his obligations to the state of Missouri. Again, this is a mirror action, essentially the same discipline imposed by the state of Missouri, and I asked the board to approve the consent order so that we can put this matter off to investigations. Yes, ma'am.
So you made mention of Maine. Missouri was the initial thing. Is the Maine issue another issue that's gonna come up, or was it a mirror action just like these other things?
It was a separate incident, but it was apparently this was a multi-state operation.
So kind of related to the same circumstance?
Yes,
Okay.
ma'am.
I just didn't know if we were gonna find ourselves doing something similar later. Okay.
And I looked into that also because Maine wasn't a mirror action, but it was the same basic set of circumstances. It's a different name.
So do we know what Missouri required Dr. Zalzala to do?
We do. The Missouri order should be behind the consent order. The Mississippi consent order, it's publicly reprimanded. He's required to notify all other states this disciplinary action within 30 days, which he did notify us. He was required to give notice to everywhere he worked and practiced. He was required to give notice to any allied healthcare professionals that he supervised. Those are essentially the terms.
Okay.
So it's essentially just a reprimand.
I was just interested because usually we require some educational measures, but this is a mirror action. We certainly do that.
Move to accept consent order.
We have a motion, we have a second.
Second.
We have a motion and a second. Do we have any further, discussion or questions? Not all in favor of the motion to approve the consent order, say aye.
Aye.
Aye. Any opposed, say nay. And, any abstentions? The motion is approved for the consent order. And, next on our agenda is, a hearing in the case of, Dr. Azaguara in Ridgeland. We have a motion for continuance.
We do, the first motion of continuance, this would be a second continuance, filed with our National Guard Council. I also agree that continuance is appropriate. The, Dr. Asaguar's attorney, filed an amended, motion to dismiss and an amended evidentiary motion in limine, raising several constitutional claims and defenses, about 2 weeks ago. Because complaint counsel, Stan and I need additional time to fully brief these issues. They are serious, related to due process. I will say I do not believe they're meritorious, but for the sake of consideration of a potential appeal, these issues are too important not to fully brief. The second reason continuance is appropriate is, you may recall in a recent case, Dr. Feinzimmer, where the board was sitting back there for quite some time while we had to resolve some pre-hearing motions on evidence and due process issues. I have agreed to a briefing schedule with Dr. Asaguar's counsel, which would permit all the briefing on this to be submitted to Ms. Morris or whatever hearing officer might be assigned before Halloween. And so that the hearing officer would have plenty of time to rule well in advance of the hearing. We can have written rulings and in advance, and when we walk in the day of the hearing, we can have the hearing. So it's for the convenience of the hearing officer as well to have time to properly rule.
Thanks, Ms.
So, I move to approve the motion for continuance.
Second.
We have a motion and a second. We have any further discussion or questions? If not, all in favor of the motion, say aye.
Aye.
Aye. Any opposed, nay? Thank you, Dr. Joyner. The motion carries. And, next is item 20 on the agenda. A motion for continuance for Dr. Story.
Yes, so this is the first motion for continuance. Dr. Story was served for this board meeting, and he has requested a continuance to prepare his defense. Since it is the first motion for continuance, you know, it's the common practice of this board to grant such motions.
Move to approve request for continuance.
Second.
We have a motion and a second. Any discussion? If not, all in favor of the motion, say aye.
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 Any opposed? Nay. Any abstentions? Motion carries. Next is motion for continuance in the case of Dr. Lesser.
This is Ms. Retcher, who is a transition assistant.
Oh, sorry.
And this is a carryover from 2 previous board meetings. Ms. Resser is in compliance with the examining committee's directives. And so therefore, we request that the board continue this matter until the executive committee fulfills its function. Examining committee. US.
Take words that begin with letter E for 400. Yeah. Move to accept the request for continuance.
So we have a second?
Yeah. Kennard.
Thanks, Dr. Kennard. we have any discussion regarding, continuance for Ms. Lester? If not, all in favor of the motion, say aye.
Aye.
Any opposed, nay? Any abstentions? The motion carries. Next is item 22. A hearing in the case of Dr. Nikita Mirio.
I apologize. That I do not see the signed copy of the consent order which was sent to me late yesterday. Ms. McKenzie is getting copies to provide to the board. I'm unsure whether or not it's been put in the materials. To beg your indulgence.
Yeah. No.
We just have a request for a continuance. Dr. Mirio.
No, this is a hearing. This is a motion for, this is a consent order. Okay.
So.
It only became a consent order 2 days ago.
Okay.
So
Right.
We don't have to consent order.
We're about to.
yeah, we're getting that for you now.
I'd like to introduce Ms. Edna Spranger and Ms. Dr. Correll. Here. And, sent me the signed consent order yesterday evening, and we're getting copies to provide.
I'm the attorney.
I believe we can proceed, and I know the terms run up in the board can confirm it, in the interest of time. This is a consent order that relates to, the charges relate to, 2 issues. First, Dr. Morrell collaborated with a mid-level practitioner who was using a laser-like device and was not FDA approved. Second, the nurse practitioner was doing some cosmetic procedures, including fillers and Botox injections, that Dr. Morrell admitted that she did not do any of those things in her everyday practice, which meant that that was not like practice as far as the collaboration rules are concerned. Second, Dr. Morrell expressed some confusion about the requirements for an evaluation of hospital patients within 30 days after they had been admitted to hospice. And she admitted that she had not. I believe we got 11 charts, and 7 out of the 11, there was no examination that had been performed. Dr. Morrell has expressed remorse, has stated that her violations were inadvertent, and again, based largely on confusion. The terms of the consent order would be a reprimand, a CME and prescribing, and an agreement to pay the investigative costs of the board. So those are the terms at this time. Unless Ms. Stringer has anything she wants to say first, I would ask that Dr. Muriel to put under oath, so the board can have answer any questions.
Yes, please proceed.
Please.
I'm sorry. The hearing
Liza
officer,
Hay.
I will defer to the hearing officer. Liza Hayes.
Yes, could you please swear the witness?
Jackie's saying that the order should be on your summons clause.
The job which I created for me, that is, all of those documents are on there. I thought they were gonna be uploaded to theirs.
See what, on this page, some copies before you move things forward. So
Can we also remember Dr. Joyner in the dissemination of the documents? Thank you.
And we have not, you have not sworn the witness in yet. You just did, okay, thank you. I just wanted to make sure.
I was inclined, I had not asked whether Ms. Stringer wanted to make any statement before I put this on.
Would you like to make a statement prior to the testimony, Attorney Stringer? Not prior. You'll have an option, to do that afterwards, yes, ma'am. Okay.
Can you all hear us?
Yes.
Okay.
Did you please swear to, Morales, please stand.
She's been sworn in.
Sworn in.
Sorry. All right, I'm gonna get straight. Morales, if you will, please. Come sit with us. Awesome. Dr. Morel, let's talk about the collaboration issue, first, because, I understand it. That situation may have changed.
Yes.
Okay, so at the time that, the board investigator, came and talked to you and inspected your practice, you were not performing the cosmetic procedures or the laser, using the laser device that the midline was using. Is that correct?
That's right.
Now, am I also correct that your current plans are to go into business with this nurse practitioner 2 days a week, in which you are planning to personally perform fillers and Botox injections?
Yes, sir.
Okay, so, and you will do that in compliance with the board's regulations on collaboration?
Yes, sir.
And it will be like practice for you and your nurse practitioner,
Yes, sir.
and you will be present at the same time as the location.
Yes, yes, sir.
Let's talk briefly about the hospice issue. I understand that you agreed that you had not done an evaluation within 30 days after entry to hospital for 7 of these patients. You expressed some confusion about the requirement for the evaluation. Is that correct?
Yes, sir.
Did you intend to comply with the board's regulations?
Yes, sir. Yes, sir.
And will you comply with the board's regulations in the future?
Yes, sir.
And you understand that the terms of the consent order are that you will receive a public reprimand, correct?
Yes, sir.
That you will agree to, or that you're agreeing to a thespian prescribing.
Yes, sir.
And you'll provide proof of completion to the board's compliance officer. And that you'll pay the board's investigative costs. Says not to exceed $10,000. That's the statutory maximum. It's not going to be $10,000.
Yes, sir.
You will agree to those terms.
Yes, sir.
I tend to the witness to you.
Do you have any questions, Attorney Stringer?
I just need her to.
I'm sorry, could you speak up a little louder, please?
Yes, I just need to clarify something that she stated.
Certainly.
Okay, can you explain to the board where the confusion came from regarding the 30-day visitation and how you got confused?
Yeah. So, initially, when I joined with, the hospice company, we were doing some visits. There was a point when we were actually getting phones and we were doing the face-to-face visits. But then it was in 2021, since it's now that in regulations, there was a law that came out that stated that the requirement for that face-to-face visit with prescribing of controlled substances was no longer required. And my understanding, or our understanding, was that those visits were, I guess the admission, the 30-day was an exception, and then we didn't have to do those visits prior to prescribing. And so that's where the confusion came, that we didn't have to do that anymore. And so we actually thought the law had changed. And apparently the law did change, but the problem or conflict is that the board has different requirements that we go through.
you all were not doing the face-to-face business after that was because of COVID, is that correct? Yes. Okay, so there was never any intent to violate the regulation. It was just confusion as to how it applied after the law. Completely different. That's all right. That's all I have.
Thank you. Do any of the members have any questions?
Did you ever do any exams, face-to-face exams on any of those hospice patients?
I did, a majority of patients, because at one point, it was almost a selling point, that, you know, we would have a physician come out and see you within 30 days of admission. And so I was doing it on all our patients up until that point. And so I think, I don't know, I guess with the patients that were, the records were full, maybe those were previously admitted or whatnot, but I was doing those visits for every patient that was admitted or something.
Okay, then, Dr. Owens.
Hi, I'm Michelle Owens, I'm board president, and an MFM here in Jackson. Just, so you were working with hospice, is it part like, is it a group, or was this something that you were just doing independently as a contractor?
As a contractor.
Okay, and your background and training, are you, family medicine, internal medicine, what's your?
Family medicine, okay.
Any further questions from a board member?
I don't know, could you just tell us a little bit more about the nature of your education and training and practice, please?
As in general, like where I did, how about that? I did undergrad at University for Women. I did a master's program at UMC. I went to med school in Meharry. I did residency in Tupelo, and then I came to the Jackson area with first hired with Merit Health, and then I did J. Carmichael Community Health Center for a while. I actually went through burnout at that point, and so I took a step back and went into a private practice with one of the nurse practitioners I collaborated with 2 days a week to kind of give myself a break, but continue to work. And I focused did a lot more hospice work. And that's when I was doing visits. And then just really wanting to get back into the field. I started with Oak Street Health, and that's where I am now. I continue my practice a couple of days a week, and I do the Oak Street Health, and then I have the hospice that I do.
So is Oak Tree Health, is that like a private?
That's
clinic?
group, it's a group, Oak Street Health, I think it's kind of new to the area, it's more for the elderly population in Medicare.
Okay, how did you get into the Botox?
I guess honestly, it was something that was going around that's like the new thing. And so I was interested in getting into it. And when I was approached at the time, it was something I was very interested in doing. I will admit that life happened. And so me actually getting the training was delayed. It wasn't that I had no intent or in purpose of doing so. Life just kind of happened. And I guess when you think like, oh, I got time or there's a chance, I kind of put things, and then, okay, well, when I was brought to my attention, like, hey, this isn't right. And it's like, oh my God, I've been working on this online course, and, now it's that reality of you gotta get this done now. And so that has been what I've wanted to do, is kind of a extra thing, because it's like kind of a new thing, really. And I was interested in getting into it. I just hate that things kind of happen this way. And, yeah.
Thank you, Dr.
Any additional questions?
I do.
Dr. Owens, go ahead.
Sorry, I should ask them all at once. So you mentioned being approached about doing, the cosmetic component. Was that something where you actually approached or by the APRN, or what, like, who, when you say approached initially, was this something where you had an idea and you said, hey, I happen to know you, you have an interest, I have an interest, let's do this? Or was this something that was brought to you as, I really like to do this, I have this skill set, would you be my collaborating physician, yada, yada?
A little bit of both, actually, to be honest. Initially, it was actually, one of the doctors, I don't know the name, but she was around and she actually wanted me to go in business with her. But at the time, it was the financial, like the burden of actually trying to start the clinic. And I thought I just didn't have that at the time. And then also, I was a little nervous because she wanted to kind of bounce us around. And I was like, I don't want to get stuck in this situation with her. And so she was like, well, get into it, you know, learn about it. I can teach you and whatnot. And so I kind of went with her a little bit, but I never fully got into it. She showed me some things, but my intent, I didn't want to go in business with her because as I suspected, she ended up leaving the state within a year. And so then in that mindset, I was thinking about it. And then the APRN was introducing me through a common friend and said like, hey, I know this lady who, you know, was gonna start a business. I know you had mentioned like some interest before. And so then that's when we went into the collaboration.
Any further questions?
I just want to clarify something. You are certified now. Okay, so, and when did you receive that certification?
April of 2023.
That's all.
Thank you. If there are no other questions, are there any closing remarks from either attorney additional? Okay, both of you rest, I gather.
Yes, sure.
All right. Then you're excused, and may take your seat.
Just make them.
You have an option. We can make a motion, or I would accept a motion on the consent order that's being offered by the board. You have an option if you need to go into executive session to discuss it. It's dealing with an infraction of the rules, and the statute. Or you can make it an open meeting.
Move to approve the consent order.
Second.
Been moved and properly seconded. Any discussion? All those in favor say aye.
Aye.
Any opposed? The motion is carried.
Thank you all. Thank you. And we can be excused.
Yes, it's excused. Here, but then I didn't have to go through. I promise you, really. The bonus award, if it gets, yes.
It's fine.
Yeah, I'll be there.
You do dental as well?
No, I have my hands full with pharmacy a lot of times because of the attorneys that are here before the board. And then I do this one, but this is calm.
Right.
It's relatively calm as to what I usually.
That's
do.
right. It usually is.
Five mic.
We have one more, I think.
Is this another consent order?
No.
We relinquish.
The next item on the agenda.
Hearing and the case back in here.
Yes.
Mr. Barnes, want to announce what the proceeding is before us?
Yes, these are disciplinary hearing, Dr. Charles Darrell Lyon Jr. MD. That's Ryan, it's just we're in the boardroom. Very briefly, because I'm gonna call Dr. Lyon to.
If you're going to call him, could I at least have him sworn in at this time, if you don't mind?
And just in opening to summarize what the evidence showed. Dr. Ryan has a history of alcoholism. He was in the PHP program and was anonymous to the board for over 6 years. He completed his participation in the program in the year 2021. The evidence will show that Dr. Ryan has told the board through Dr. Cleveland that he remained sober for another 2.5 years, but that he relapsed. And from my calculation, I'll ask him, but that would be around the December or the 2023 or the end of 2023. However, when he fell off the wagon and began drinking again, Dr. Ryan continued to practice medicine. He was culminated on March 19th, 2024. Dr. Ryan is an OB. Dr. Ryan, in an impaired state, did a procedure, a cesarean section and a tubal ligation while he was impaired. The staff noticed that there was something off about Dr. Ryan's conduct and behavior. It was determined that another surgeon was called in to complete the procedure. It was determined that Dr. Ryan was in fact impaired. And the hospital suspended Dr. Ryan's privileges and ultimately filed a data bank report concerning the incident because they suspended his privileges for longer than 30 days. So as required by law, they reported it to the National Practitioners Data Bank and this board. After investigating, Dr. Cleveland determined that charges were necessary. Dr. Ryan has reassociated with the MPHP program. He has signed a new contract. However, Dr. Ryan agreed and that he understood that the fact that he was reassociating with MPHP would not preclude disciplinary action for his conduct and endanger the lives of these two patients. Again, by my rough calculations, Dr. Ryan practiced medicine for about 4 months while he was impaired. After he relapsed, he did not report himself to MPHP. He did not seek help, despite the fact, because of his long previous association with the MPHP, he knew the dangers, he knew the risks, both to himself and to his patients. And therefore, the charges are that Dr. Ryan was disciplined by the medical staff of the hospital and that he is also guilty of unprofessional conduct. And in his response, Dr. Ryan either admitted each of the allegations or did not contest the allegations. So if you, and I'll direct you to where the affidavit is in the materials, it's on page 52. But Dr. Ryan has not disputed any of the facts which I've just described. But because this is such a serious breach of ethics and the standard of care, I feel it's important that I point the board to some specific points in the record. And so at this time, I'm going to offer into evidence documents bearing Bates numbers MSBML 1 through 79, with the exception of pages 70 to 71 and 74 to 76. Those pages related to another complaint regarding medical records or minor thing that were included in the documents produced to Dr. Ryan's attorney, but they have no bearing on this matter.
Could you repeat those pages, please?
Yes, ma'am. The full span of the documents is MSBML 1 through 79. The exceptions which have been removed are pages 70 to 71, pages 74 to 76, which will not be offered. Dr. Ryan was represented by an attorney, Mr. Tommy Williams of the Charles Williams firm. However, Dr. Ryan, as I understand it now, is acting.
And I would like to radar him about that matter before you proceed any further, since you're gonna call him.
Yes, sir.
Dr. Ryan, I noticed in the notice that you received from the Medical Licensure Board that you were given the opportunity and advised that you could be represented today by counsel.
Yes.
You do understand that, but you do understand that you did appear voluntarily on your own visit today.
Yes.
So for the record, we want to point that out. You may proceed.
And the board's convenience, the documents are on the Surface Pro. I do have a couple of extra copies, hard copies. I have one for the board. Dr. Ryan, I call Dr. Ryan to the stand. Yeah, proceed.
Yes, please.
Dr. Ryan, my name is Paul Barnes. I'm the county counsel for the board. We just met for the first time today. For the record, would you please repeat your full name and your profession?
Dr. Charles Gerald Ryan, OBGYN.
Dr. Ryan, would you please describe the circumstances that led up to the event on March 19th, 2024, involving the cesarean section and tubal ligation?
I had stated before relapsed a few months prior to this. The evening before and the morning of, I had drank alcohol and proceeded to go to the hospital and operate while under the influence.
Okay. What happened during the procedure?
We were able to get the baby out without any problems, plug the uterus, performing the tubal ligation. One side was performed and the second side was being done, and then I was relieved by the on-call surgeon.
In fact, you were tying off the round ligament instead of the fallopian tube, is that correct?
Is my understanding.
Okay. So a second physician had to relieve you and to complete the tubal ligation, correct?
Correct.
Okay. Where did you go? Were you directed to leave the operating or delivery room, or did you voluntarily remove yourself?
Yeah, they suggested that I be evaluated.
You say, did the staff in the room, did the nurses, et cetera, say anything to you? Did the other physician come in and say, Dr. Ryan, let me take over? Exactly what happened?
Yes, the other physician came in to relieve.
Okay. And after you left the procedure room, where did you go next? Did you go to the emergency department?
Correct.
Okay. And was your blood alcohol level checked?
Yes.
What was it?
I don't know exactly.
But you agree it was in excess of the limit for driving?
Yes.
Okay. Let the record reflect that I provided a copy of the exhibits to the witness, so I can ask him a few questions.
And they have been admitted by error, so it's fine.
And Dr. Ryan, I mean, you have not denied the allegations in the affidavit. You have admitted everything that I've said, and I do not want to belabor these things. However, there are a few specific places in these documents that I need to ask you about, because the board has to determine what discipline is appropriate for your behavior. If you would turn to page 5, and I'm referring to the base numbers at the bottom right. Turn to page 5. This is an email from June 27th, 2013. You see that?
Yes.
And this is from you to, someone at the, hospital credentialing committee. Is that right?
Correct.
Okay, and you state that, on March 15, 2013, you arrested or stopped and arrested for, suspected DUI in Georgia, correct?
Correct.
All right. Then if you turn to page 9. Excuse me, 14. Now, this appears to me to be, from your reapplication for privileges to the hospital from May 19th, 2015. Do you agree with that?
Yes.
Okay. And you state in a response to question 5 that you were arrested for suspicion of DUI on 2/13/15 in DeSoto County, Mississippi, correct?
Correct.
Were those DUI charges ever resolved either in Georgia or in Mississippi?
Yes.
Were you found guilty?
Yes.
Both charges? Okay. Answer to question 2, there on page 14. I'm not going to read the entire material, but you refer to a diagnosis of alcoholism, that you've been through 10 weeks of inpatient treatment. You were undergoing intensive outpatient treatment. It signed a 5-year contract with MPHP, and that the board had never suspended or revoked your license. And that was true and correct in 2015 at the time you sent this document. But again, that was after you had reassociated with PHP and after you have been through inpatient treatment.
In 2015.
Yes, sir, in 2015. All right. Now, if you back up to page 9. This appears to be a letter from Judge George Burris, MD, did I pronounce that right? Is that, who was Dr. Burris?
Looks like he's the chair of the credentialing committee for Baptist Memorial.
Okay. So it appears to me, based on the first paragraph, that after you were arrested for that second DUI in February of 2015, you requested a voluntary leave of absence so you could go for inpatient treatment. Is that correct?
Correct.
Okay, and this letter in March is granting your request, correct? Okay. And on page 15, Dr. Ryan, this is a letter on the Mississippi Professional Health Program letterhead dated June 12, 2015. It's only the first page. Oh, no, excuse me. It's both pages. And this is what the reference is advocacy letter for Charles Ryan, MD. And this letter confirms that you had associated with MPHP, that you participated in the program and had signed a contract, correct?
Correct.
And this letter was submitted by MPHP. And then as you flip through the next few pages, there are several more in subsequent years where MPHP provided advocacy for you so that you could reobtain and then retain your privileges to practice medicine, correct?
Correct.
All right. If you turn to page 20, letter dated June 21st, 2021, first paragraph, this is from Kristen Powell, LCSW at the MPHP. The first paragraph states that effective 5/5/2021, Dr. Ryan has successfully completed all contract requirements with MPHP and is no longer an active participant in the MPHP academy. I've read that correctly, didn't I?
Yes.
So at that time, had you been sober from 2015 to 2021?
Yes.
Okay. On page 21, at the bottom of the page, there's an email referring to the incident on March 19th that we discussed a little about the C-section. And as I look at this email thread, a precautionary suspension is mentioned, and let's see, the email at the bottom of the page says this is in follow-up to our call this afternoon concerning Dr. Ryan presenting to BMH DeSoto today impaired from the effects of alcohol use and therefore being unsafe and unfit for clinical practice. I'll read that correctly. Yes. And so you were summarily suspended, your privileges were summarily suspended at that point.
Yes.
Okay. Now, there's a lot of redactions on these medical executive committee minutes to protect the identity, the information related to other positions. If you turn to page 26, you see the one reference that isn't redacted. Again, is just officially reporting that you were found to be impaired and that there was an immediate precautionary suspension of your privilege. Correct? Correct. The next page, 27. It's a letter from Brad Parsons, the CEO, to you. Again, this, I believe, is just a written letter confirming that the precautionary suspension has been issued. You agree? Yes. Page 28. The email at the bottom of the page is to a Dr. Mason. Who is Dr. Mason?
He is the Chief Medical Officer of Baptist DeSoto.
Okay. And without going through all of this, I would say that this is appears to be what I would call an advocacy letter in the form of an email from Kristen Powell with MPHP to Dr. Mason, confirming that you have reassociated with MPHP and that you have signed an agreement not to practice. And Ms. Powell says that she wanted the committee to have this information before making a decision whether to lift your suspension, and she expresses her hope that the suspension would be lifted. Correct?
Correct.
Right. If you will go to page 32. Now, this is sideways, but at the top of the page, these are minutes from the Medical Executive Committee specially called meeting to discuss Charles G. Ryan Jr. MD from March 28th, 2024. I would direct your attention to the second paragraph. There are several descriptions of the incident in these records. This one perhaps is the most complete, so I would like to read it into the record. On March 19th, 2024, Dr. Charles Ryan presented to BMH DeSoto and performed a planned C-section and tubal ligation. During the procedure, staff became concerned with Dr. Ryan's behavior and care of the patient, and a second surgeon was called to complete the tubal ligation. It was subsequently confirmed that Dr. Ryan was impaired. A precautionary suspension was imposed immediately to reduce the imminent likelihood of significant danger to patients at Baptist Memorial Hospital, DeSoto, and to consider clinical concerns about Dr. Ryan's practice, which, if confirmed, have the potential to adversely affect patient care. Is there anything about that description with which you disagree?
No.
The next page, 33, it's in the second complete paragraph. And I simply am looking at the phrase again, this is referring to the same procedure that you presented or performing it while impaired, created an imminent and substantial risk of serious harm to both the mother and the baby, and resulted in an unintended outcome during the tubal ligation, which required a second surgeon to repair. Your decision to perform these procedures while impaired could have been life-altering or life-ending for either of these patients. Is there anything in that description with which you disagree?
No.
On page 36, this is so the record is clear. This is a letter to you from Brad Parsons dated April 12, 2024. Is that correct?
Yes.
And I'll just summarize the substance. This letter appears to me that Brad Parsons is giving you official notice that your suspension will last for more than 30 days. And therefore, it would be reported to the National Practitioner Data Bank and the State Board of Medical Licensure, correct?
Correct.
The next page, 37. This is an email from the National Practitioners Data Bank to Kim Colbert from at the hospital, confirming that the data bank had received the notice of action and had been viewed by the State Board of Medical Licensure on April 12, 2024. So, do you agree with that interpretation?
Yes.
Just dot all the i's and cross the t's. On page 46, would you turn to that page? This is a summons for you to appear today for a hearing. The charges, at that time, you were represented by Mr. Tommy Williams, an attorney, correct? Correct. And you had authorized Mr. Williams to accept electronic service on your behalf, correct? All right, turn to page 52. This is the affidavit of Ron Horner, an agent and investigator for the board. And again, we've already discussed the substance of this affidavit. Again, I just point out in your answer or response, which is page page 63 begins. Let's see, and I'm comparing the two, but paragraph 1 of the affidavit, which is on 52, you admitted that those allegations, didn't contest paragraph 2, you admitted paragraph 3, admitted paragraph 4, did not contest paragraph 5, and you did not contest either count 1 or count 2. Those charges are count 1 is being disciplined by the medical staff, the hospital. Count 2 is unprofessional conduct, which includes, but is not limited to, being guilty of any dishonorable or unethical conduct likely to deceive, defraud, or harm the public. And you didn't contest either charge, and you do not contest either charge.
No.
If you turn to page 67. Judge Ryan, do you recognize that as a letter that you sent to the attention of Dr. Cleveland on July 19th, 2024?
Yes.
Do you recall the context of this letter was that you were asking Dr. Cleveland to approve your new contract with the NPHP?
Correct.
And do you recall the discussion that Dr. Cleveland would not agree to sign the new contract unless you confirmed that you understood that his agreement to your contract did not preclude or waive the right of the board to take disciplinary action?
Yes.
And down toward the bottom, do it. Strike that. And Director Ryan, page 72, this, I believe, is a letter from a Mary Catherine Chamberlain, a letter of support for you, as I would describe it. How do you know Ms. Chamberlain, and what is your relationship to her?
She was the director of the OB hospitalist program that I was at Soto, and was aware of my practice.
Did you ask her to write a letter on your behalf?
I did.
On page 77, appears to be a letter addressed to me of September 9th, 2024 from Claudia House. Can you pronounce the last name for me? Niebank.
Yeah, Niebank.
Niebank. This also appears to be a letter of support. Did you ask Ms. Niebank to write a letter on your behalf?
I did.
And on page 79, I believe this was an attachment to the letter that Ms. Niebank sent. It's dated May 4th, 2022, from Lynn Fitch, Attorney General of the State of Mississippi, praising the work that's done at Save a Life of DeSoto County Care Pregnancy Resource Center. You've seen that before.
Yes.
You stated that you had been consuming alcohol on March 19th of 2024, the night before and the morning of. When did you stop drinking?
Um, 5 a.m.
Okay, so you've been drinking all night. Okay, what time was the procedure?
8:30, 9 o'clock.
AM.
Yes.
So you stopped drinking, drank all night, stopped drinking around 5, the procedure was 8:30.
Yes.
Dr. Ryan, you've admitted serious offenses. You've admitted that you have a problem with alcohol abuse. You reassociated with MPHB. What do you have to tell the board? What would you like to tell the board that might potentially mitigate the discipline the board might issue for you? And you could direct it to the board.
I cannot express to you the magnitude of embarrassment and shame that I have for those actions over 19. I have endeavored to atone for those both in my heart and in my actions since then, going through treatment for 10 weeks, being sober, confirmed by blood test and urine test over that 6-month period. I've reestablished with the 12-step program, going to that, as well as other requirements of the PhD, seeing a therapist and monitors in place. I feel confident that I can remain sober because I've done it before. While on monitoring, I was never had a positive test, and like I said, was sober for 8.5 years during that time. As to why I went back, I think it was a combination of maybe a lapse in my spiritual condition, perhaps not being as vigilant. I was on vacation where it happened initially, and I think I just lost the fear of the perilousness of this disease. I realized that practicing medicine is a privilege, and I think that I have demonstrated through treatment, and I also requested a letter from my psychiatrist that they did several tests to make sure that I was still competent, neurophysical, and everything. I feel confident in my ability to practice medicine, and I ask that you allow me to do that again.
Dr. Ryan, because you referred to that, I know that we have the discharge summary from your treatment at Talbot Recovery in 2024 Go get a copy of that. However, we did not receive the complete chart from Talbot. We only received the discharge summary. And, the release that was signed by you, only had the box for the discharge summary checked. Can you explain why?
I would be happy to release any records that they have. I thought that I had checked everything to their satisfaction.
Do you recall in the last 2 weeks receiving a request from Kristen Wallace, the compliance officer of the board, that you signed, an additional, release permitting a release of all of your chart from Talbot?
I'd be nice to receive that notice.
Attend the witness.
You have already given a statement, Dr. Ryan, so are there any questions from members of the board at this time? There being no question, I'm sorry.
Yeah,
I'm sorry, Dr. Lippincott.
thank you. Hey, Dr. Ryan, so, you were under contract with the MPH from 2015 till 2021, is that correct?
Correct.
And that was a 5-year contract, is that correct?
Yes.
And, during that time, you were, going to AA meetings, 12-step meetings, and vicious meetings,
Yes.
and, upon completion of your contract, did you continue going to those meetings?
I did.
How often were you going to the meetings?
I was going 2 or 3 meetings a week.
12-step meetings?
Yes.
And, you were practicing in Mississippi, correct?
Correct.
And were you going to the vicious meetings?
I was not going to do.
Not after you completed your contract. How often did you go to those, vicious meetings?
They were once a week.
Yeah. And where were they located?
In Memphis.
When exactly did you relapse, Dr. Ryan?
Around September of 2023.
And did you have any warnings or, concerns before you actually drank?
No, I said earlier, I was on vacation. I wasn't planning on drinking. I just wasn't as vigilant as I should have been. And yes. Thought I was okay. I don't know.
So, what kind of treatment did you have back in 2015?
It was a 10-week inpatient treatment at Bradford in Warrior, Alabama, and then I went to intensive outpatient treatment for 3 or 4 weeks afterwards.
And, when is the last time you had a drink?
March 19th, 2023. Or 23.
When did you go to Talbot?
I think that was March 25th of 2024.
And, what did your treatment there at Talbot involve?
It was also an inpatient treatment of lectures, testing, group therapy, individual therapy.
Was your family involved in that treatment?
Yes.
And is your family supportive of your recovery?
Yes, they are. Are
you back how often are you going to these, work step meetings now?
3 or 4 times a week. Yeah, sometimes more,
And, how often do you go to this meeting?
weekly.
Well, how do you feel about your condition at this time, Dr. Lamb?
Let's say before, I feel confident that I can remain sober. I did get a lot of insight into perhaps why the relapse happened and ways to prevent that from happening again.
Thank you. That's all the questions that I have.
Dr. Owens?
Michelle Owens from Tropical Medicine in Jackson. Dr. Ryan, my question is, so when this issue came up, in the operating room, is this the first time that you've ever, performed a procedure or operated while under the influence?
Yes.
So no other time had you ever gone in? What was it that if you had stopped drinking earlier that morning, did you have a moment when you're headed to the OR, I don't know if this was a scheduled C-section or if it was a section that just ended up being called, but at any point, was there a time when you were like, maybe I shouldn't do this? Was there a partner that you could have called? I mean, I know we don't always call out as physicians, but like, was there a point where you might have, where you considered, even just kind of looking back, I mean, did you have somebody who could have backed you up?
I suppose I could have let the hospitals take care of it. In my fair state, my judgment was affected. I did that.
And so, and you drove yourself to the hospital before your procedure?
Correct.
That's all I have.
Any further, Dr. Logan?
That's Ryan, J. Logan. So just go a little bit more into the difference between now and then. So why do you feel better about this situation? This isn't going to come up again as opposed to many big things. Say before it was baffling to me why I did have the relapse to begin with. And so I did some real soul searching to try to figure out why it did happen. And as I stated before, I think some of it was the lapse in my spiritual connection, a pride in thinking that I was different. And then just a lack of vigilance or forgetting the dangerousness. And I never thought that I would be the one. I would hear about relapses, and I thought I never considered that to be me. But I think I just lost the fear of it.
Yes, if you wouldn't, this wouldn't have happened, if you would have been caught in trouble that day, would you still be drinking these things, or would you have finally stopped? And tell me, again, I'm trying to understand, I guess, what's the mindset? The difference in the mindset, I guess.
I'm sure I wouldn't reach a point where I couldn't have gone on. And so, no.
Any further questions?
Yes, back in 2015, how did you come to be a treatment at that time?
Because of the second DUI, I knew that I needed to have some help.
Okay. And so you have a contract with the NPHP now.
Correct.
What's the duration of that contract?
It's a 5-year contract.
So what assurance do we have that history is not going to repeat itself?
And I would be willing to continue random monitoring as long as I continue to practice medicine, if that's what it's doing.
Thank you.
Dr. Ryan, what is your support system like? Because I noticed when we ask you questions, you rely on yourself. All of your answers start with I, but do you have a support system in place? Like when you were getting into these situations, is there anyone who can recognize your triggers or may be able to pull you aside and say, hey, I think I need to slow down or do something with that? Because no man is an island unto himself. So
It is hard for me to ask for help. But I now have, I didn't have a sponsor at that time in the 12-step program. We have a sponsor that you heard to call beforehand. I had one initially, but we kind of fallen apart. But I do have a sponsor now. I meet with them every week. Call whenever I need. Speak with them. I have a son that lives at home with me. I have friends that I can rely on, both in the program and outside of it. As well as the continued therapist that I go to. Medical.
Dr. Owens, you have another question?
Lauren. So, one of the things that you said that really kind of stuck with me is when you talk about that loss of vigilance. And I think, you know, one of the things that when you struggle with substance use disorder or addiction of any kind is recognizing that it's really kind of like a chronic disease, a chronic illness. And so so it's always about doing something where you have to exercise a level of control. And you might not necessarily always be on the same medication, but there always has to be this sense of controlling that part of your life. So I just think hopefully that's helpful. I've found that for some of my patients, it's helpful to them to think of it as a chronic illness or a chronic disease. It's not something that you ever really get over, but it's something that you live with. And in living with it, that's really, and remembering that you're living with it is really that kind of the best way to overcome it. But when you said that to me, it was just something that that came to me, and I've heard that many times, that concept of treating it as though it's just something finite. And I think that's one of the challenges in a recovery, because the longer that you have, the easier it can sometimes be to forget that even though it's well controlled, it's still something that you have to have some level of intention about it.
Anything further from the members of the board? If not, Mr. Barnes.
Thank you. At this time, before Dr. Ryan takes his stand, I'd like to offer some additional documents for the record. First is a 2-page discharge summary for Talbot Recovery Campus for an admission of March 25th, 2024. The next page is a unsigned authorization consent release information that has all of the possible types of information checked. It's unsigned. The next page is an email dated September 17th, 2024 from Kristen Wallace to Dr. Ryan, asking him to sign and return the complete release. And then the last page is the authorization and consent to release information that Dr. Ryan did provide, dated 6/17/24, where only the discharge summary is checked as being permissible information. And so I'd ask that this be, admitted into the record.
Any objection, Dr. Ryan?
No.
Okay, there being none, you can mark those as exhibit 2 and 2, okay, composite.
If we have copies, I just wanted the board to have the benefit of the records that are available. And I do have a couple more questions when you're ready for me to proceed.
You may proceed, Mr. Barnes.
Dr. Ryan, if you would look at the physician discharge summary that was just handed to you from Talbot. Have you seen this before?
No.
Okay. If you look, the very top under diagnosis, psychiatric diagnosis, alcohol use disorder severe. Do you agree that your alcoholism is severe?
Yes.
Under problems treated, dimension 1, the last sentence of that paragraph, there's a typo, but he was advised of the potential risk of reinstatement of substance use, including a fatal outcome. What was discussed with you by Talbot about the possible fatal outcome?
Well, it's, one of the board members stated this is a chronic disease and, resumption could end in physical manifestations that could eventually cause death.
And that's for you personally, correct?
Yes.
He wasn't referring to the patients which you performed the procedure on when you were impaired, was it? No. But there was the potential for an even more serious or negative fatal outcome when you performed that C-section, right?
Yes.
Dr. Ryan, I believe Dr. Owens asked this question, whether you performed any other procedures while you were impaired, and you said no. Is that right?
Correct.
But you started drinking again around September of 2023.
Yes, it wasn't an everyday occurrence.
Did it become an everyday occurrence?
Yeah. Probably toward January or February, yes.
But you were well aware that by practicing while impaired, that you were putting your patients' health, well-being, and their lives at risk.
Yes.
Based on the questions that were submitted, additional ones by Attorney Barnes, do the board members have any questions?
I have one last question.
Dr. Kennard?
Yeah, Dr. Ryan, since you started Manjaro, are you continuing that?
Yes.
Do you feel like your cravings, or did you have cravings, number one? Once you're in remission long enough, you probably get past hourly and daily cravings, but did it do anything for cravings, number one, or number two? Do you think it helps you in your abstinence?
I wasn't having any cravings at the time that I relapsed, and since I have left treatment, I have no cravings at this time. So I don't really know whether the Manjaro helped or hurt with that.
There's some current evidence to suggest that it does help with alcohol and other substance craving. It could be a tool in addiction. So I was curious as to if you had a personal testimony.
I'm going to continue it with the diabetes.
Sure.
Any additional questions? Mr. Barnes, do you have any closing statements since there are no questions?
I do.
Go ahead.
I have no further questions for Dr. Ryan. If you'd like, Brown, step down.
Yes, sir. Would you like to make a, you can step down as well. Get finished.
In closing, I would just like to say the record is clear It is natural to feel sympathy, for Dr. Ryan and his, struggles with addiction. However, I feel I would be remiss if I did not remind the board that, this is not just about Dr. Ryan. And perhaps most importantly for this board, it's about Dr. Ryan's patients. The patients that he placed at risk that day. And, there's no way to tell how many other patients he may have placed at risk if he had not gotten caught, I think, as Dr. Livingston said. And while certainly one of the bases for discipline is the way it affects the individual practitioner, but another reason and basis for discipline by a professional licensing agency and board is the message that it sends to the medical community about what is and is not acceptable behavior. Deterrence is one of the prime reasons for discipline. And obviously it is well within the board's discretion as to what action to take with regard to Dr. Ryan. But in my mind, deterrence is a very important issue for the board to consider. That's all I have.
There being nothing further on this matter currently, it's time to take, I'm going to entertain a motion on whether or not the board, feels that they have, to make a determination on whether they have a proper subject for executive session.
I move that we close the meeting to consider whether to go into executive session.
Second.
So be it. So we will, basically adjourn, recess at this time and make an announcement as to that determination. We are now back in open session. The board in executive session will now read what the disciplinary action will be regarding this matter. Dr. Canal.
Thank you. Madam Hearing Officer, may have something to add, but I will read what the decision was after much deliberation. We are issuing a 1-year license suspension, as well as completion of courses in the disciplines of ethics and professionalism, which will refer you to the executive director for the details of life of practice contract with the PHP and the mandatory appearance back before the board to request reinstatement when you're eligible.
That being the order of the board, I do want to point out that there will be boilerplate language that will be in addition, that will give you the protocols of the order when you receive it, in conjunction with Mr. Barnes, the attorney for the board. This concludes the hearing in this matter.
Thank you. The last item 24 is for the November board meeting dates. Does anyone have any problems with the projected dates for Wednesday, November 20th and Thursday, November 21st? If not, we didn't entertain a motion to meet on those dates.
Yeah, make a motion.
Or need a motion. We'll see you then, right? Okay.
You do need one to adjourn.
Do we have a motion to adjourn? Dr. Owens.
So moved.
We have a motion. Do we have a second? Do we have any further discussion? Not, all in favor of adjournment, say aye.
Aye.
Aye. Any opposed? Meeting adjourned.
Oh my gosh.